और ये जॉर्जियन मीट नहीं आए?
नहीं मैं नहीं आ पाई थी उस दिन।
Hi, Dr. Ruby.
So, support team here. 3,
Hello, ma'am.
2, 1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave. I am medical advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for the Synergy 10 webinar on the topic optimum ultrasound machine setting and normal and abnormal pregnancy at normal and abnormal location. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः.
I would like to introduce Dr. Monica Singh. She is the convener of Synergy Academic Club webinar. She is president-elect of Bhopal Obstetrics and Gynecological Society. She is founder-president of ISOVAP chapter of Bhopal. She is national executive member of ISAR. She is also joint secretary cum joint treasurer of MPIAG, and she is also coordinator of Foxy Infertility Committee. Now over to Dr. Monica Singh.
Thank you. Thank you, Team Intas. Thank you, Dr. Vishal, for getting the Synergy webinar together. Today, 20th of February, Thursday, 4 p.m. onwards, we are starting this very exciting webinar of one of the series in which I want to carry on with ultrasound. And we know that this is one topic, even people are very excited with endoscopy. People are excited about basically high-risk pregnancy, about genetics, but ultrasound is one tool where you need to be passionate about if you want to advance in any field of OBGY, be it obstetrics, gynae, infertility, anything. So I'm very grateful to our team for getting this together at very short notice. And today the Synergy Club is synergizing with Association of MP OBGY Societies, also popularly known as MPOX, the Cancer Prevention and Relief Society based at Raipur, and the Sagar OBGY Society. So these three organizations have been clubbed together or synergized together to give this live webinar, episode 10 of Synergy, on optimizing the ultrasound machine settings, because we were having too many webinars with biology. That is why we thought that let's use the term of optimizing your ultrasound machine settings, which will involve not only the knobs, but also the, how you adjust your vision, how you know your probes, how you place your probes. And we have the master wizard with us, Dr. Kuldeep Singh, to walk us through this. Followed by a very, very interesting panel on normal and abnormal pregnancies at normal and abnormal location. 1 hour is too less for this huge topic, but we have this galaxy of panel experts who will again discuss with Dr. Asha Jain and myself, just a support there in order to, get the correct nuances. And we also request Dr. Kuldeep Singh to be there during the panel in between his work so that he can throw light onto this enigmatic topic and very, very important topic. So can I have the flyer again, Dr. Vishal, where I will welcome our dignitaries. We are very, very happy and honored to have amongst us Dr. Professor Kavita N. Singh, ma'am, who is not only the president of MPOX, she is also the dean of Gandhi Medical College, Bhopal, and the governing council member of ICOG. So, madam, we are honored to have you here. Madam has got a minute-by-minute programmed day throughout, but she has spared time for this webinar, and I'm so grateful to her. To introduce ma'am is like lighting a candle in front of the sun. But still, I would like to introduce her as the professor and head who did wondrous work in the OBGY department of NSCB Medical College, Jabalpur, followed by phenomenal work in the field of gynec oncology. She has been trained in US as well as Tata Memorial, Mumbai, the Regional Cancer Center, Trivandrum. She is WHO CRO trainer colposcopy with more than 2 decades teaching experience. Ma'am, I know you're short of time.
You can shorten it, it is already
yes, ma'am. So, ma'am, I would just
no.
A very big MPOX conference next year. She is holding, she's looking
You have
after
to learn a lot. Yeah.
And madam, we are so blessed to have you every time you enter this program. It is with something new, and we are always honored to have your presence. Ma'am, few words from you, please.
Monica, for the kind introduction and invitation for today's webinar. And as you know, me, at least MP knows me for my interest in academics and surgery. So, well, so whenever I get an opportunity to connect all of you and learn something which I really, nowadays being into administration, the chances has gone down, little down. So I don't want to miss any. And as far as today's topic is concerned, that is optimum USG settings and for normal and abnormal pregnancy at different locations. So this is the topic. I think this is a common OBGYN person's topic. Maybe a person can be in PG or just entered into the practice, or maybe a senior like me. Because listening from Dr. Kuldeep and all other experts, it's like again revising what we know and adding on to what we don't know. And I can see Shabana, Purva, Juhi in the team. So I would expect all of you to note down, take proper notes of important settings, because very soon I'll get you 2 machines for your department at GMC. I want GMC OBGYN to have best of machines and best of facilities. So that you have to note down. And
Thank you so much, ma'am.
yeah, and I can see Richa also from Jabalpur. So Richa, I'm so pleased to see you in the platform. I miss home a lot. Yeah.
Yes,
But,
ma'am, we miss you too. Jabalpur misses you.
yeah, but after all, it is our mother state, that is Madhya Pradesh. There also I was in a serving position, and here I am in the same. So that's all. And my best wishes for today's webinar. Monica, dear, you are doing so well. And as a president, I congratulate you, and I'm looking forward for a fantastic tenure. My best wishes are with you.
Thank
Over
you.
to you, Monica. Thank you.
Thank you so much, ma'am. Your words are always like nectar to us, and they give us a lot of hope and encouragement. Now, I would like to introduce our guests of honor. We are very pleased to have Dr. Pratik Tambe with us. Can I have Sir CV? Dr. Pratik Tambe is not new to Synergy. He has been with a number of our series webinars. He has been a speaker. He has been a guest. He has, spoken a lot about different topics. And he is a mentor, advisor, teacher to many of young postgraduates and even like older people like me who like to take advice from him. He is a big name in Mumbai, OBGY Society, as well as MSR, National ISAR. We can see that he's headed not only the governing council of ICOG, but also the newly started Indian College of Reproductive Medicine, where he's a governing council member. He is a very important part of MOGS, ISAR, MSR. He has been in the helm of affairs in the FOXY Endocrinology Committee as well as the AMOGS Endocrinology Committee, which is, of course, an asset to whatever work he does in infertility. Recipient of several awards, written so many books, chapters. So we are so pleased to have you, Pratik. Please kindly address our gathering.
Thank you very much, Dr. Monica Singh, for inviting me to this very prestigious Synergy series. Congratulations on getting it up and running and continuously through passion, dedication, and concerted effort with your own team, putting it forward month after month and going on to the 10th episode. It's really a privilege for me to be here in the midst of all these luminaries and great academicians. I'm sure all of us will be very privileged to learn from a teacher of teachers, Dr. Kuldeep Singh. I have had the privilege of seeing him live in person on more than one occasion, and I can assure you that he is a fantastic teacher. All of us are going to immensely benefit from his talk. In the 1990s, when I was a resident doctor in a municipal hospital, it may interest you to know that there was only one ultrasound machine, which was come to us second hand. And all of us residents in the OBGYN department used to fight to get 5 minutes with that machine to learn, you know. Fast forward to today, where without ultrasound, a gynecologist in clinical practice, especially those of us who practice infertility, simply cannot think of practicing, because that has become like an extension of our mind and of our body. I'm sure all of us will benefit from Dr. Kuldeep Singh's lecture. And there's a fantastic panel that I see that is going to be moderated by yourself and Dr. Asha Jain. Dr. Asha Jain has recently taken over as the chairperson of the Foxy Food and Drug Committee. Congratulations to her. I'm sure all of us will benefit from that panel as well. Again, thank you for inviting me here. And Monica, I wish you all the very best for your future journey in Foxy as well as ISAR. We hope to see you take both these organizations to greater heights, and I'm sure you will do more than justice to your position when you take over as the president next year of Bhopal Society.
Thank you. Thank you so much, Dr. Prateek, for those encouraging words. It's always nice to have you in Synergy. So now I would like to welcome and warmly welcome my own president of Bhopal Obsgynae Society, Dr. Abha Jain ma'am. Madam has taken over our society of more than 370 members recently, and she took over on 19th of January. She is going to be our president, Bhopal Obsgynae Society, for the next 2 years. She is one of the pioneers of IVF and ICSI in Bhopal. She started IVF infertility in Bhopal way back in the 90s. And then she started a full-fledged IVF center in 2010. We've always, looked up to her for guidance. She served Bhopal Obsgynae Society in the capacity of Secretary, VP. She is an alumnus of Gandhi Medical College, Bhopal. And Madam, we are so happy to have you and would like to have a few words of blessings from you. Abha, ma'am.
Hello, Monica.
Good evening,
You are
ma'am.
really a star, and you are doing a lot for academics. And we Bhopalis are very proud of you because you are shining not only in Bhopal, in MP, and also at national and international levels. And I pray to God that you continue this as academician and give education to young people as well as all of us, because we all need to be updated nowadays, otherwise we'll be old timer. So thank you, Monica.
Thank you, Abha ma'am. Ma'am, you can never be old timer, because I would like to add a word about Abha ma'am, that years before the community gynec practice started, Dr. Abha Jain was the one who always worked with 3-4 young gynecs in her hospital. And she nurtured them so well. They have their own identity, they have their own practice, and they work as a team. So that is one thing, Abha ma'am, I really admire you for. And you are a boon for Bhopal. I'm sure Bhopal Society will blossom under you, and we will leave no stone unturned to work and support you in whatever endeavor you make. Thank you, ma'am.
Thank you a lot.
Thank you,
Best
ma'am.
of luck.
Thank you. Thank you so much, ma'am, for joining. We hope that you will stay on in the program. And now I invite our special guests. In fact, before we go to the special guest, I would like to again acknowledge the presence of Dr. Kavita N. Singh ma'am as President MPOX. Since Madam has already blessed us, we would like to go to Secretary of MPOX, Dr. Dipti Gupta, again, a very, very dear friend from Jabalpur, who has worked, totally in sync with Madam in order to bring MPOX forward. We are seeing the level of activities which are going on in MPOX, which can, match any other organization of the country, whether it is Tamil Nadu, Maharashtra. So this is with the concerted efforts of the President and Secretary. Dipti has held several positions in the state level in Jabalpur, as well as she is very active in Jogi. She is an IVF practitioner, a medical college teacher, and written several books and won several prizes. So Dipti, a few words from you, please.
Thank you so much, Monica ma'am, and thank you for having MPOGs and on behalf of your committee, that is the Perinatology Committee. We're actually grateful for being an active member and contributing actively. And congratulations for this series. And like everybody said, I am also eagerly waiting to listen to Kuldeep sir. And like you correctly said, I think ultrasound and endoscopy particularly are two areas where understanding our equipment very well and being very comfortable with it is very important to get the best out of our imaging and diagnostics, and then, of course, the procedures. So, eagerly looking to a very interactive academic session. And it is a pleasure to be here with so many dignitaries, so many seniors and friends, and of course, ma'am, who we dearly miss all the time. So, over to you for the rest of the session. Looking forward. Thank
Deepti,
you,
please
ma'am.
invite everyone for upcoming RIVA conference also as a secretary.
Yes, ma'am. So we have our interim state conference, that is the 16th AMPOG state conference being organized by RIVA OBGYN Society on 28th and 29th of March. It will be preceded by a one-day workshop exclusively on critical care and obstetrics, followed by a half-day workshop on endoscopy. And we would really look forward, and we would be more than honored to welcome everybody in RIVA. I am sure it will be not just an academic feast, but a good, close fellowship and gathering where we can all just connect with each other. So I would be posting the flyer in the chat box. If anybody's interested, please feel free to contact me or any of the organizing team. Thank you so much for that reminder, ma'am.
Thank you. Thank you, Dipti. And you can post not only in the chat box, you can post the flyer of the
In the
conference
groups, ma'am.
and the link in the group also, in the Synergy
Yes,
10 group also.
yes, ma'am.
Because
Thank
it
you
is
so
our
much.
conference and every member of MPOX should head towards Riva and
Yes.
enjoy the hospitality and the warmth of the team over there. So now we move on to our special guest for the evening. We have special guest Dr. Shabana Sultan, Professor and HOD GMC Bhopal. And of course, Sagar Society has been kind enough to collaborate with us. So we have the President of Sagar Society, Dr. Jagriti Kiran Nagar, and Secretary of Sagar OBGYN Society, Dr. Swati Patel. Can I have the series, please? Dr. Shabana is always a constant, star in our program, not only as a guest, as a speaker, as a mentor. She was with me 30 minutes back. We were in a very important meeting, but now she is back in the program. She wears multiple hats on her, able shoulders and head, and she is juggling between so many responsibilities of college, everything. But her passion is PPH and her passion is oncology, and she's got some very fantastic news to give us regarding just now a very key achievement she has made in the field of oncology in the state. Congratulations, Dr. Shabana. A few words from you, please.
Thank you, Monica Didi. I'm audible?
Yes, you are.
Yeah. Thank you so much, Monica Dee, for making me a part of this procedure series of webinar. And so many congratulations to you of actually completing more than 50 webinars. I'm correct? And
Yeah.
the topic you is very interesting. Like always, it's very important for my student also. So it's important for every obstetrician, gynecologist, and students. And I'm also eagerly to listen to the expert, Dr. So congratulations for the webinar series and thank you so much for involving me. And Kavita ma'am, I was actually driving. So thank you so much for giving us more ultrasound machines. We have two and now you're giving us two more. So our Dean Madam Dr. Kavita Singh ma'am. So thank you and all the best for the series.
Thank you, Dr. Shabana, and happy sonographing to you in GMC Bhopal. I hope your department is flooded with machines. Every ward, every OT, every place, and that madam can achieve that target.
Yeah.
So
Madam is
now I invite our special guest from Sagar, Dr. Jagriti. Again, a very, very dear friend of mine, always says yes to all my invitations. She never says no to anything. I mean, this is a record. Anything I want, I just call her and she says yes. So she is heading Sagar OBGYN Society. Everybody knows in Foxy how many awards Sagar is winning and always wins. This is just because of her leadership. She is associate professor in Bundelkhand Medical College, a very sought after government medical college in Sagar, MP, which is one of the, heart cities of India. Welcome, Jagriti. And we would like to have a few words from you. Jagrati, please unmute.
Thank you so much, ma'am, for such a kind words. And congratulations to you, ma'am, for consistent efforts and great academics and doing 50 episodes of Synergy. And I wish all the best for your election. And you are really so helping and signing a star of MP. And we wish all the best to you, ma'am.
Thank you. Thank you so much, Jagrati. And please stay on for the webinar. Call all your Sagar Society to watch and hear Sir speak and Asha Madam speak. And now I would like to welcome your secretary. Is she there? Is Dr. Swati ji there?
No, ma'am, she hasn't joined yet.
Okay. So we will introduce her whenever she joins. Before I start, Purva, with your permission, I would like to introduce Dr. Asha Jain, ma'am, because she is the key person around which I actually framed the webinar around two people. That was Dr. Kuldeep Singh and Dr. Asha Jain. This idea would not have, taken shape if Madam was not there. She is like my elder sister. She has recently taken over as the chairperson of Foxy Food, Drug and Medico-Surgical Equipment Committee. And this is a very apt committee because she's so passionate about fetal medicine, ultrasound, OBGY. She is, a colposcopy trainer. She's a very busy practitioner, very helpful, a keen academician. And she shared with me that she never shares the same presentation twice. Can you imagine? So many presentations she must be having, but she always makes a fresh presentation for every program. So welcome, Asha ma'am. Are you there?
I'm very much there.
Ma'am, please, can you speak a few words for us?
Nothing to say. Great academics. Namaskar to everyone. Kuldeep sir, Prateek sir. Regards from Raipur. And I hope we are all going to have an academic feast. I heard that the questions I've made for the panel are a little difficult. If sir will be kind enough to just stay on for some time, it will make the panel so much more interesting. So sir, I invite you to be our expert if you stay back for some time, after your lecture. And let's just go to the academics and have a blast.
Yes, ma'am. Surely, ma'am, you are the last station and now our train is going to go like Shatabdi now or Vande Bharat. So now we come to our coordinators. We have 3 coordinators with us, the Wonder Women around whom this program rotates, and we'll have 2 more coordinators from next season onwards. So Neetu Mishra is there, Purva Bhatkur and Nandini Singh Bhati. All the phone calls, all the messages, all the WhatsApp has been done by them. I have been just the director sitting comfortably. They have done all the jobs and got you the ICOG points as well. So welcome Purva and welcome Nandini. The stage is all yours now. Please start the session number 1.
Thank you so much, ma'am. So moving to our academic session, know the optimum settings for your ultrasound machine, routes and techniques of ultrasound. I call upon Dr. Kuldeep Singh sir to throw light on this topic. Now, next I invite our chairperson, Dr. Sunita Arora madam, Dr. Sujata Agarwal ma'am and Dr. Monica Singh ma'am. Dr. Sunita Arora ma'am, madam is presently the President Delhi chapter ISAR. She is also Vice President Delhi Gynae Forum South and has received various awards like Eminent IVF Specialist Award, Dr. APJ Abdul Kalam Appreciation Award, Dr. APJ Abdul Kalam Excellence in Teaching Award, Matritva Ratna Award, Proud Foxian Award, Dr. Kusum Pandit Award, ISAR Champion Award, and Sir CS Dawn Award. We welcome you, ma'am, to chair the session. Next, we have Dr. Sujata Agarwal, madam. Madam is presently Secretary of Delhi Chapter ISAR. She is Editor, Delhi Gynecologist Forum South, South Zone Coordinator, Menopausal Society of Delhi, Executive Committee Member of Adolescent Health, AOGD. She has she is presently Director IV Health and Infertility Center, South Delhi, and she has received various awards like Dr. APJ Abdul Kalam Appreciation Award, Dr. Subhash Mukhopadhyay Award, ISAR Appreciation Award, Icon Award, and is a very active member in various national conferences. We welcome you, ma'am. Next, we have Dr. Monica Singh, ma'am. Madam is
Skip me. So I think the chairpersons can introduce sir.
Dr. Kuldeep Singh, sir.
Okay, so it's my privilege to introduce my junior, and we all are proud of him, Dr. Kuldeep Singh. He's a teacher of teachers, a master trainer in field of ultrasounds, and he has got a very nice center in Delhi where he's teaching all the students from various parts of India. He has got many books published in different languages, not only in Hindi, English, in Spanish, Chinese, and he has received so many awards for his work in ultrasound, like Imaging Science Award in AOCG Delhi. And he has got many books related to ultrasounds in fetal medicine. And we all know when he speaks, everybody is just एक तरह से बोलते हैं ना कि कुछ सुनते ही नहीं है, सर की बातें सुनते रहते हैं और भूल जाते हैं कि चैप्टर कब खत्म हो गया. So Dr. Kuldeep, we welcome you to present your topic.
Thank you, ma'am. Thank you so much. Thank you, Dr. Monica, for giving me this opportunity, and it's always a pleasure. I'm just going to start sharing the screen, and it's amazing that the Synergy has almost done. I hope you can all see the screen, more than 50 webinars. That's amazing. And there are plenty of workshops and conferences that you keep on doing. Is my screen visible? Am I audible, Ji?
Yes, sir.
Yes, sir.
So it's basically indirectly or directly, I'm going to be talking about knobs, and it's not only about just knobs. It's going to be how you're going to be using those knobs very judiciously, because it never can be for this patient, this particular setting is okay for me. And so it means it's going to be okay for you also. So how you're going to be using it, how you're going to be having your eyes accustomed to it. So my talk is divided into two portions. One is going to cover up the 2D basics, where we're going to be looking at how to look at things on 2D. And then it's going to be, the second talk is going to be on color flow mapping, power angio, and duplex Doppler. There are plenty of you who are members of Sono School, and we're going to go by the phenomenon of we question, you answer, and learn. I'm just going to be taking this a little down so that then I can see it comfortably. Now, why do you really need to be optimizing the image? It facilitates correct interpretation. It recognizes sonographic characteristics of normal, abnormal tissues, structures, blood flow, adapts protocol. So you need to be having your image clearly, because if your image is not going to be good, you're not going to be making a good diagnosis. It's your responsibility to optimize the sonographic image. Whenever you buy a machine, Dr. Kavita ma'am said it's going to be in GMC Bhopal, they're going to be newer machines coming, but it's not the application expert who's going to be doing the ultrasound. It's going to be you who's going to be doing the ultrasound. So avoid the presets, avoid the easy buttons. Let those presets be there, what the machine walas have done. You're going to be making your own presets, looking at how to make the brightness, the contrast for various sets of patients, and I'm going to be explaining that to you. A machine cannot assess the image like a professional can. The use of various knobs or toggles to improve the visual quality of a diagnostic ultrasound image is what is image optimization. I'm not going to be today telling about the probe movements and all that, because that would be too huge. Might be one of these days whenever we have something like in terms of gynecology, we're going to be covering up how to use your transabdominal and transvaginal probe. What are the movements like? There are many tools available. You don't have to really remember all this. It's all there in your machine, and it's not if it is at a particular location at my machine, it's going to be there in your machine as well. You just need to know how you're going to be looking at it and what are the changes you can do. The two dictums that we follow in Sono School, the eyes are going to see what the mind knows. So there are plenty of times when I finish this talk is when you're going to be really going back to your machine and seeing where exactly it is, and it's all there in the machines. Second is, if anyone can do it, you definitely can do it. Now, if you're looking at the probes, transvaginal, we're looking at the small parts, we're looking at a 3D convex sector, and we're looking at a convex sector over there, which is a normal 2D. These are the presets that they've given to me in terms of obstetrics, in gynecology, in abdomen. Right now, because the obstetrics is clicked on, I've made an OB for myself. I made a heart for myself. You can always go into the NT. You can always make an early pregnancy as well. Transabdominal probe, transvaginal probe. And you can easily use this as a translabial or a transperineal, where you're just going to be wearing a glove, put a blob of jelly, put this probe onto that, and deglove it on this probe, and your translabial or transperineal probe is ready. What you need to remember when you're using this nowadays, it's not that it is just 2 megahertz or 3 megahertz or 5 megahertz. Nowadays, you have probes from 2 to 9 megahertz transabdominal and 5 to 12 megahertz transvaginal. So what you need to remember is if the frequency is going to be higher, which is obviously in this, the resolution is going to be better, but the penetration is not going to be that great. I'll just show you with a few images just now. So if you're using a broad spectrum one, let's say you're using it from 2 to 5. So if you're going to be using the 3 to 4 frequency, that's a general frequency. If you need a penetrative one, you're going to be using 2 to 3. And if you need a higher resolution, you're going to be using 3 to 4. Now, where do I need to use it? If you're looking at an obese patient, you're going to be reducing the frequency so that the sound waves penetrate more. Similarly, if you're looking at a bulky uterus, let's say this probe is 6 to 9, then you're going to be using the 6 to 7 band so that the sound waves can travel more, they can penetrate more. Higher the frequency, higher the resolution. Higher the frequency, lesser the penetration. Higher the resolution, lesser the penetration. You need to remember that. Just by a little knob change is what's going to make a change. Just reduce the frequency and you're going to be looking at a good image. I think so somebody's mic is on, Jay. Adjusting the frequency allows you to increase the resolution at the expense of penetration. Most transducers are broadband. Adjusting the frequency will display a frequency range, not a single frequency. You're looking at the frequency here. So if it's PEN, that means penetrative, the lowest of the band over there. If you're using the mid-range, that will be GEN, that's general. And if you're looking at the highest frequency, that will be RES, that is resolution. Now see over here, you're looking at a penetrative one over there. That's the penetrative one there. You can see over there, you can nicely see this portion over here. I've now gone on to the resolution, and the resolution is RESH. That's a high resolution. I can't see over here. Might be I could be missing out on a fundal fibroid, though I'm getting a good image than this. This is a better image because the resolution is better. Now what I can do is, this is resolution high, I'll go to resolution low, which is giving a good penetration and giving me a good image so that I can see the myometrial cyst much more clearly, myometrial vascularity seen as well. So you need the highest possible frequency setting that allows you to see the anatomy you're viewing. Higher frequencies provide the best resolution, but you could lose penetration in that. Now there's something called as the sector size. Again, it's not going to be as if it's going to keep on changing on its own. You'll have to change it. And where do you really need the smallest sector size is when you're looking at the fetal heart, especially when you're trying to do an echocardiography. So if you increase the sector size, the frame rate is going to reduce because your machine is now will have to work more. So if you're going to be reducing the sector size, the frame rate is going to get better. That's the scanning area. I'm scanning over here. The frame rate is 41. I've reduced it. The frame rate increases. Higher the frame rate, the better is going to be the picture quality. So that's the only way you're going to be doing it. Reduce the scan area. Now, if you're going to be using this, and the moment you reduce it, your machine doesn't have to work here and here. It's only working here. You reduce the depth, the frame rate is also going to go better. A good image quality is fairly subjective. It's relative to the capabilities of the machine. Two people looking at the same image will have a different perspective on what is good. Might be I say this image is good, you would say, no, this is okay. What you could be saying is good, I mustn't be liking it. So there are basic image optimization techniques. All these settings are there in all the machines, but you'll have to change it from patient to patient. We have a gain control, TGC controls, focal zones, frequency selection we've already talked about, and opto optimization or the presets that you can choose. This is going to adjust the overall brightness of the ultrasound image, the gain adjustment. This is the chapter which we always say, no, this is a boring chapter, we're not going to read it. But the problem is, whenever you say my machine is not good, it's because we're not using our machine nicely. You buy a 1 crore machine, but if you're not going to be using it or you don't know how to use it, you're never going to be getting a good image. So then there'll be no point blaming the machine for that. You can always rotate the knob and have your increase or decrease in gains. This is dark image. This is too bright image. This is fine. But exactly depends on what you like and for. You can always have that image for yourself. Now, when you're looking at this, this is overall gains, overall brightness. But if I want to reduce the gains in a particular portion, what am I going to do? I'm going to have time gain compensation control. They're going to be adjusting the gains in specific areas. And I'll tell you why is this done. These are the TGC knobs. This is what the zebra effect is. I'll come to the previous slide just now. I want to explain how we're doing it. I'm just increasing it here, increasing it here, increasing it here, and then I'm going on to the mid portions. I need a homogeneous image. So what I'm going to be doing is I'm going to be making my TGC knobs a little to the left here, little to the right here. And why is that to be done? Because if you're going to be moving the upper ones to the left of the center, the low ones to the right of the center, you're going to be looking at a homogeneous image. That's the way to really do or use your TGC knobs. Now, why do we need to do it? I want to explain it here. The moment the ultrasound waves are going inside, they're going to be reflected back with the same frequency. They go a little down because of attenuation, because of reflection, because of absorption, because of scattering. What is going inside is going to come back in almost the same range, but because of the attenuation, the intensity goes down. Intensity goes down. So what do I need to do? I need to reduce the ones that is coming back and increase this a little more. That's how I'm going to be using my TGC knobs. That's how I'm going to be using it smartly. We're looking at various TGC knobs, various settings. You could be liking this, I could be liking this. Whichever way your eyes are set, do that accordingly. Ideal way to use is TGC knobs. Never am I mentioning that you have to take it absolutely to the left or absolutely to the right. Might be you can have it like this. Whichever way you're comfortable, use it. The bottom line is you should have a great image. Focal points. Your machine now all have autofocal points. The ones which are a few years old, you need to might be take your focal position a little up and down. It all depends on where is the region of interest that you're looking at. You can always change the focal point from here. The image resolution improves in the area of the selected focal position. You can increase the number of focal points, but then you're going to be reducing the frame rate. I purposely kept this focal point here. If you see over here, the fetus is here. Why am I having my focal point here? But the moment I take it here, I can see so much of information. I can see the amnion. I can see the yolk sac. I can see a little limb bud over there. I can see a little cavity in the brain. I'm going to be obviously zooming it again, but just with the focal point, I'm looking at a few more things. That is what is needed. Just a little bit of using the machine correctly, optimizing it correctly. Ideal position is at the level of or just beyond the area of interest. What happens is from the side, this increases or betters the temporal resolution. Axial resolution is along the ultrasound waves. Temporal resolution is at 90 degrees. The lateral resolution gets better. It enhances the image in a specific region. As the depth changes, the focal point also changes. You need to be, again, I've seen so many images where you're looking at the uterus high up and somebody's unnecessarily wasted so much of depth. You're telling your machine to work unnecessarily, and that's why it is not functioning optimally. So you need to just have a proper depth. Do not waste the far field. The depth should be 2 finger widths from the bottom of anatomy to the bottom of the image. Do not clip the anatomy. Utilize the depth throughout the study. If you see over here, all these measurements are a centimeter. That's a centimeter over there. So if you see over there, the uterine portion is finishing off at around 12 centimeters, and I am unnecessarily taking them up to 19 to 20 centimeters. I'm telling my machine to work this much to send sound waves here when it could suffice here. Again, you'll see just with a little change, you can see the whole thing come up so nicely. I'll just now let you know how to zoom the image also. That's also very essential. You're looking at a high depth, unnecessary wasting this. You're clipping the anatomy over here. You don't need to do it. Ideal would be here. You're looking at the diaphragm. You're looking at the liver. I cannot see the uterine fundus. I'm unnecessarily wasting so much. This is around 12 centimeters or 14, and I'm seeing up to 48, 49 centimeters. What am I trying to do? Can't even see anything here. This is ideal where I'm looking at it's a retroverted uterus, and I can go ahead with zooming the image. That's why using the fetus over there, neutral position. So whenever you're zooming the image, it should always be in the center. Always remember, your sound waves are going to be best at the center of this and at the center of this. That's where you're going to get your image, and you can zoom it nicely. And always a live zoom is better than a frozen zoom. You're getting the uterus here. This is ideal depth that you're looking, and then you're going to be zooming it. You can see the vagina portion, vaginal canal, cervical canal, looking at the endometrium there, the fundus, the corpus, looking at the posterior wall nicely and comfortably. You can either have an overall zoom, or you can always press the zoom button and get a zoom box. You can take the zoom box wherever you want. If supposedly you need to zoom it here, you always have to do it with the zoom box. Or you can have an overall zoom and zoom the image properly. These are the basic features: overall gain, TGC, focus, depth, zoom. Now we come on to a few advanced features that you need to use now, because what we were doing 10 years ago, we can't be doing the same thing still. We need to be getting smarter and smarter. Our machines are getting smarter. You can always use tissue harmonics. But again, a word of caution. It's not if it's an advanced feature, you have to use it everywhere. You have to use it judiciously, properly. It allows the ultrasound to identify body tissue and reduce artifacts. All the sound waves that are coming, all the echoes that are coming back, There will be few which will be weak. There will be few which will be strong. Again, depends on what thing are you going to be using. Either it will accentuate the weaker signals or filter out the weaker signals so that you get a good image. So that the noise finishes off, the weaker signals finish off. You can use your harmonics. You're looking at a nice endometrium, nice junctional zone, nice myometrium over there. The other advanced features, in some machines it's called DR, that's dynamic range. In some it's called dynamic compression. Some have both of them. You can have gray maps. Again, all these are trying to do is make the weaker signals stronger or filter out the weaker signals so that you only get the smarter ones. That's dynamic range. And if you see over here, you're looking at this is the portion which is highlighted. It can be changed with these knobs over here. So if this is highlighted, you can change it with this knob. The moment this is a touch screen, I touch this, this will get highlighted and I can change it with the knob over here. What does a dynamic range or a dynamic compression do? Basically, we earlier on when we started, we had 128 shades of gray. One end of the spectrum was white, the other end was black. Then we had 128, 256, 512. Now we have more than 2000 shades. So the more the shades, the dynamic range is going to be better. Now, again, not necessarily that if I like this image, you're going to might be like this image. It depends on, I'm looking at the fetal heart. I want to see the flappy movements of the valves. I'm going to be using this or this because this is going to become too homogeneous, too uniform to give me a good image. It always depends on, if you're looking at the fetal phase, you would not like this, might be you'd like this image. That's where you're going to be changing the settings so it can never be uniform. Showing you a few examples of changes in the dynamic range. You can all see over here, the things are going to change here, the values are going to change here. It all depends on all these are showing me the triple layered endometrium, showing me the myometrium. Whichever way you are comfortable, you'll be able to see these images. You can change the dynamic range, change the dynamic compression. Now there's something called as a gray map, and which is very, very useful, especially when you're doing your antral follicle count, when you're trying to look at a cyst over there so that you get more sharper and clearer images. What the dynamic range does is, it tells us about the overall number of shades of gray. What does a gray map do? It makes each and every shade darker or lighter. I'm going to be showing you a few examples of those. Dynamic range increases or decreases the number of gray shades. Gray map adjusts the brightness of each shade of gray. The gray maps. I'm showing you the knob on my previous machine and showing you the pictures of my new machine. There. Nothing except the gray map has been changed. Whichever way you are comfortable, that's most important. Just the gray maps have been changed in these two images. All the four of them. Different gray map. Now, what does the frame rate do? If you're going to be increasing or decreasing the depth, obviously your machine has to work less. It's going to give you a better frame rate. The number of pulses per frame depends on the number of focal points, the sector size, and the line density. The more work we ask the transducer to do, the more time it takes to do it, slowing the frame rate. And you need the highest frame rate whenever you're looking at the fetal heart, especially when you're doing your 11 to 14 week scan, especially when you're looking at a fetal echocardiography at between 20 to 24 weeks. Now, if you see over here, that's my sector size. I'm getting a frame rate of 21. I've reduced, getting 26. But there's no point doing this, getting a good frame rate when I can't see the uterus properly, so I have to do it properly. So these are the things for advanced features you need to do, looking at tissue harmonics, dynamic range, and grayscales. Those are the three common ones. I think so. I'm over with the 2D one, and I'll just now start off with the color flow as well. There, look at the frame rate. I'm looking at a frame rate of 13. I've reduced the depth. I've reduced the sector size. Look at the frame rate. Look at what I was able to see here and what I'm able to see here. I can see all the three cavities in the brain nicely. I can see the cranial portion. I can see the trunk portion over there. Looking at a limb bud over there. The difference is I made a change in the frame rate. So in terms of critical thinking skills, you should know the protocol. Critique your images, evaluate your image before you save it, go off axis whenever needed, video clip of it, it's a still image, you cannot tell the complete story. If you have a question, the person who's asked you to do the ultrasound would obviously have it, and be humble enough to get someone else to look at it. I'm going to now start off with the color portion so that then I can tell you a few things over there. Again, we need to be smart enough over there. How to really do that? Where are we going to get stuck? Whenever you're looking at or doing a color Doppler, especially in pregnant patients, you need to be following the principle of ALARA. That's as low as reasonably achievable. So you need to follow that principle. Don't unnecessarily keep the probe on the patient's abdomen and keep on chatting with somebody about some report or the other. You can always keep the probe back, hold on for 2 minutes, finish your thing, whatever you're doing, then start off again. Now, what do you really understand with the color Doppler? It's going to tell us about, let's say these are the two things that happen. If I'm going to be stationary and there's an ambulance or somebody coming with banging the horn and gradually coming closer to me, obviously what I'm going to hear is much more. Goes away, it's going to be again reducing. Let's say the horn is stationary and I am moving towards the car or towards the horn. I wasn't able to hear it too shriekingly. Now I'm able to, and then I'm going away. That's the same pattern that the RBCs are going to follow. This is going to be your probe, which is going to send in ultrasound waves, but the RBCs are moving here. This is what happens. The ultrasound waves are gone. By the time it's time to come back, the RBCs come closer. RBCs come closer. But over here, when it's time to, you're sending in a little more, but what's coming is a little less. We're not going to mug up this formula over here because it's not at all useful. What you need to follow here is what is cos theta. That's the angle between the ultrasound beam and the axis of flow. And remember, cos 90 is 0. So if any of the things is going at 90 degrees, you're not going to be getting any color. So don't get worried. Even on a 2D, I can see over here. That's the neck portion. I can see 2 loops of cord. I don't need a color Doppler. But what happens is when I switch on my color, I'm not looking at any flow there. Only reason being, it's coming at 90 degrees. The moment I toggle my probe, I'm able to see the 2 loops of cord. So don't get worried. Why am I not able to see? Are my machines going bad? No. You just have to see in the center, you're barely seeing any flow, but on the sides, plenty of flow over there. Plenty of flow on the sides. B mode has the lowest power output. M mode, color flow, and spectral Doppler have a little higher output. So it should always begin with B mode and use the color and spectral Doppler only when necessary. If I go by the order, B mode would have the lowest, little more on the M mode, again a little more on color, and highest on spectral Doppler. When you're using your system, you should be clear that it should be showing you the peak systolic velocity, the end diastolic velocity, telling you about these 3 indices, pulsatility index, resistive index, SD ratio. What do these 3 indices indicate? They just tell us about resistance to flow. So if these values are high, meaning the resistance is high, meaning the blood flow is less. So if I'm looking at brain sparing, that means the blood flow is going more to the brain, so the resistance is reducing. So I'm going to get a PI which is going to be less. That is why the umbilical artery PI, if it goes above the 95th percentile, or the middle cerebral artery PI goes below the 5th percentile, is when the alarm button gets pressed. Various settings over here we're looking at. Everybody's machine has it, so do not worry. That's for the color. The moment I'm going to be pressing this, I'm going to be getting a color box over there. What all are the Doppler effects that I can see? The commonest is color Doppler. Then we have power Doppler, which we're going to be telling you where exactly in which scenario to use. And then we have spectral Doppler, where we can quantify. We're looking at normal 2D. We're looking at color Doppler. We're looking at power angio, power Doppler, and we're looking at spectral, where I'm getting waveforms. Those are the things that I can change, and I'll tell you how, where, and when is it necessary. I press this button, and I'm going to be having a box over there. Color Doppler is the most commonly used term for color Doppler. It tells me about overall view of flow in a region. It displays the blood flow in two colors, red and blue. Red and blue has nothing to do with, sorry for being very basic, in terms of veins or arteries. It just tells me the direction of flow. Flow towards the transducer is red, away from the transducer is blue. So it's the phenomenon of BART, blue away, red towards. And it can be interchanged by just the invert switch, so don't worry. What are the things that you can change? I normally looking for only these three things: the box size, the gains, the pulse repetition frequency, PRF, or velocity. You switch on the color Doppler, there's going to be a box. There was a 2D picture, you switch on your color, and you're going to be knowing about information in that box. Where is the vessel that you're looking for? It is going to identify the vessel, and you can always interrogate it with spectral Doppler. You can increase or decrease the size of the color box with this. The machine is processing the B mode information. So the number of B mode images in a unit time is called frame rate. So why can't I have the color box covering up the whole B mode? There is no point, because I'm going to be reducing the frame rate too much. And higher the frame rate, better is the scan quality. You need to keep the box as small as possible, only to include the studied area. Don't make it too small also, but such so that whichever vessel you're trying to look at, there is a sufficient length of vessel. I need to be seeing the umbilical artery over there, comfortable. I don't need to be making it so small, because the baby could just move away. Or I don't need to be doing this because I'm going to be unnecessarily reducing the frame rate. Not this big, not this small. This is absolutely appropriate. Now, there can never be a preset for how much should the color box size be. It all depends on, if you're looking at a fibroid, might be you require a bigger one if it's a large fibroid over there. Second thing comes on is the gains. And the gains have to be adjusted in order to prevent noise or artifacts. The moment you increase your 2D gains, that's called as 2D noise. If you increase the color gains, that is color noise. And I'll show it to you on spectral Doppler as well. Because if you increase it, you're going to get a random display of color dots. I've reduced the color gains. So I'm barely seeing anything. I'm not even able to look at it. There is no point. Ideal. But if I increase it, I'm unnecessarily getting these random dots. This is too less. This is too much. This is ideal. When you're switching on your Doppler, it should show you the blood vessel filling up, no color spilling. You're going to be using your gain adjustments. And how do you do that? Just by changing the color knob clockwise or anti-clockwise. If the gains are too high, the color will be seen spilling. If the gains are low, you're not going to be able to see it properly. You're looking at a fibroid there. You've termed it a leiomyoma. That's the endometrium. You're looking at a posterior wall subserous fibroid, figure 5. Now, by unnecessarily increasing the gains, I am feeling as if it's a leiomyosarcoma. Not at all needed. We're basically looking at the vessels over there, and that's sufficient. Sufficient. If I increase it, I'm not doing a good job. Then is the pulse repetition frequency. It's the velocity of the flow that we're looking at. The scale, velocity, PRF, all the three things are the same. Different units, whether you're looking at hertz, that would be the pulse repetition frequency. You're looking at velocity, centimeters, meters, or whichever per second is the scale or the velocity. You need to select an optimum PRF. If you're using a high PRF for low velocity flow, you're not going to be able to see. Basically, it means if you're looking at more than 40, only the vessels with more than 40 centimeters per second are going to show you color, the ones below. And we all know that the veins have a lower velocity, arteries have a higher one. Let's say if I need to see for something at 15 centimeters per second, I'm going to reduce the PRF, but then the ones that were at 40 or 50, they're going to show me turbulence. And what does that turbulence mean? It's called as aliasing, mixing up of colors. The red will have an orangish, the blue will have yellow with it. That's how you're going to be changing the scale by this knob or wherever your knob is. I'm looking at the velocity. See the velocities here. The moment I'm looking at the umbilical cord, I can just see the artery. I'm not able to see the veins over there. I've reduced it now and I can comfortably see both of them. But if I reduce it further, I'm unnecessarily looking at turbulence, aliasing over there. Too much of mixing. This is ideal, this is too high, and this is too low. So if you set a velocity, the vessels above will show up. Below that will not. And in high PRF, the venous flow does not show up. In low PRF, it shows turbulence or aliasing. When you're looking at flow in the heart, it always has to be high flow. When you're looking at, let's say, the carotids or you're looking at the lymph vessels, it always has to be high. But if you're trying to look at the veins, you need to reduce it. You need to be looking at fetal vessels. You're going to be looking at arteries at around 30 to 40 centimeters per second. You need to look at the ductus venosus, go a little lower, around 20 to 25 centimeters per second. Again, no fixed rules, depends on how the patient is, how big the fetus is. If the PRF is high, low velocity vessels will not be displayed on the screen. The PRF settings have to be optimum so that the color homogeneously fills the entire vessel with single color. That was for color, where you need to change the box size, where you need to be looking at the gains carefully, and you need to be changing in terms of PRF or velocities properly. Power flow, power angio, it's sensitive to low flows. There is no directional information in some modes. Nowadays, we have HD flow that can show you red and blue as well. Where do I really need power angio? That's power Doppler or power angio. Basically, this is not angle dependent. It is not the RBCs moving, it's the energy that's depicting the blood flow signals. With the movement of the blood or of body tissues, color signals will be generated. I'm looking at a degenerated fibroid on a power angio, I'm looking at plenty of flow. If I'm looking at endometrial flow, if I'm looking at perifollicular vascularization. In your infertility practice, you need to be switching on your power angios. Looking at endometritis, bright endometrium, little fluid over there, plenty of vascularity, definite endometritis there. It basically picks up low velocity blood flow, and this can even looking at vessels perpendicular. So if you're looking at, let's say, a follicle here and the upper portion does not show up on the color, you're going to be using your power angios. Irrespective, when you're looking for endometrial flow zones or looking at what is the amount of perifollicular vascularization, use your power angios. If you're looking at the uterine arteries at day 14 to see for the trigger or to look in for the embryo transfer, then use normal color Dopplers. Now, on a 2D, you figured out where all the vessels are. Now, what do we need to do with all those vessels? I need to be examining the flow at one side. I need to do a detailed analysis so that it allows me calculations of velocity and indices. That's where I'm going to be looking at spectral Doppler. You need to be careful. The fetal breathing, baby movements, fine, you cannot be controlling that. You just have to wait patiently. But there are plenty of times, especially in the third trimester, when mama is a little breathless, you can just tell her to hold on a breath for 4-5 seconds so that you can get a clean, neat signal over there. Color flow identifies the vessel and defines the direction. Spectral Doppler quantifies the amount of blood flow. That's when I'm going to be pressing this and getting my spectral Doppler on. These are the things that I can change, and I'm going to be showing you how those are going to be done. The same thing as red towards and blue away, the BART, in the spectral Doppler. Above the baseline is flow towards the probe, below the baseline is away from the probe. The arterial flow is going to show you spikes, and the venous flow is going to appear flat. And you have the scale over there. That's the baseline. I can lower it down. I can take it higher up. So if this is equally divided, this is 25, 50, 75, and 100. If I take this up, then I'll just be left with a few over here, depending on what sort of a waveform am I looking at. Arterial flow. That's uniform venous flow without spikes. Arterial flow is going to show you spikes. That's aliasing because I'm looking at a low velocity, a low PRF. The baseline can be up and down, or it can be side to side, whichever way you're comfortable. You're looking at a baseline here. You're looking at the velocities here. You can make your calculations. For any reason, if the baseline is here, do not worry. Either you can pull down the baseline, or you can always and always just do a Doppler invert. How do you optimize your spectral Doppler? Looking at the sample volume, looking at the gains, looking at the pulse repetition frequency, wall motion filter, and the sweep speed or the trace speed. All the 5 things, there's so many times where you need to be changing it. Don't need to remember it. It just becomes a matter of habit. What's the sample volume? It's the selected length of the vessel that you're assessing. You cannot be increasing the size of that equal to. You cannot. You can increase only and only. This cannot be changed. So this is the blood vessel over here. You can just insonate or figure out how much blood flow in this region. You can increase or decrease the size of the sample volume, but not over here. The line can be swapped across the entire image, and that's what the equal to sign or 2 lines are. This is what we call the SV or the sample volume. Sample volume. I can reduce it. If you see over here, that's the sample volume, 0.5 of a millimeter. If the sample volume is smaller, now if you need to remember that the blood flow at the center of the vessel is always with a higher speed. Outer portion, because of the friction, is at a little lesser speed. So if your sample volume is not proper, which it should be, so that it correlates well with the vessel thickness. So if you're going to be reducing it, only the central vessel or the higher velocities are going to be seen. Optimal insonation is complete alignment. This will tell you about absolute velocities and waveform. I'm using a much higher one, where I'm looking at the artery also, the vein also. I need to be having it equal to the width of the vessel. The moment I increase it, you're looking at so much of overlap over there, both sides. Your waveform should be nice and clean, not shadows over there. This is because I'm using a much bigger sample volume. Same thing as I said for 2D. If you're going to increase the gains, there's going to be noise. 2D noise. For color, it's going to be color noise. For spectral, it's going to be spectral noise. Gains have to be enough so that you get a clear, well-defined waveform. Gains are high, noise. They are low, then you're not going to be able to see it. Unnecessary increase in the gains, there is no point. Reduction in the gains, I can't see a waveform. This is ideal. Very less, very high. In very high, I don't know where this is terminating. So where do I put my first cursor for the systolic flow? Here I do not know because it's too low. This is absolutely correct. I'm getting a spike over here. That's how you're going to be increasing or decreasing the spectral gains. Third thing is, one was sample volume, then we were having gains. Now we have a PRF or a velocity scale. As I told you, on the side of the waveform, you're always going to have a scale. If you're looking at a very high PRF, you're going to be basically looking at very small waveforms. That's the scale. The correct PRF setting should be that the waveform spectrum fills up 2/3 of the spectral area. Now, if I'm looking at over here, I'm looking at 24, so this will be like 8 more, 32. I'm not able to see where the peak is. Now, the question that comes to me on my WhatsApp is, how do I measure it, sir? The problem is, I'm not using the correct PRF. The moment I increase the PRF, and you remember this is around 32, this would be 36. I increase the PRF and voila. If you see over here, the velocity was around 70 centimeters per second. So if this was 32, it was going up and then again coming down here, you'll never be able to get a clear cut waveform. This is the correct way of seeing it. Then we have a wall motion filter. Again, it has to be correct, and it is considered correct only if the spectrum touches the baseline. If there's a gap between the baseline and the spectrum, means you're using a high wall filter. And why is it so important? I'll explain that to you. This is the baseline. I'm looking at a filter over here, which is filter 3. Always remember, we do not need to change the filter in your machines. It always has to be the lowest filter. That's why I'm not able to see waveform here. I have to reduce it so that then I get a clear cut pattern. I'm still using F2. I'd like to have F1 over there. I can still see a little black line over there, black band superior to the baseline. This is the correct one where I'm looking at F1. Now, where does it pose a problem? I'll explain that to you. I'm looking at good flow in the umbilical artery. I'm looking at 25, 26 weeks. There's plenty of flow in diastole. I can always measure it and see the PI. The filter is 1, the lowest one. The moment I increase the filter, I'm going to be in trouble. You have to set it as low as possible to eliminate the low frequency noises from peripheral blood vessels. If you're going to be using a higher filter, you can get a spurious effect of absent end diastolic flow. Now, if I say absent end diastolic flow and try and terminate the pregnancy, I'm making a major mistake. Because whatever you're doing, there has to be flow here. Even if there is absent, then it will come here and go like this. So if you're not looking at, or there's a black band over here, you know you're using a wrong filter. The sweep speed, it should be fast enough to separate and clearly see the successive waveforms. If you're going to make it too fast, there's going to be barely one waveform. If you're making it too small, becomes too cumbersome, the baby could move and you'll not get a good tracing. That's the sweep speed. Now I'm barely getting one over there. It was moving so fast. This is ideal, where I'm looking at good plenty of them. I can see and I can measure it. But if I'm using this, I'm again making a mistake. The baby could jump on anywhere and I'm not going to be able to get neat, clean settings. Sometimes taking a measurement as to where is going to be difficult. This is ideal. Too fast, ideal, too slow. So when you're looking at the spectral Doppler settings, you need to be careful of the sample volume, the gains, the PRF, the wall motion filter, and the trace speed. Again, my humble submission is everybody's machine is very good. It does not matter what the other person is doing. Whatever knobs, whatever settings are there, whatever settings you can do, try and do them nicely, and you'll all of a sudden feel your machine is also very, very good. Rather than changing the machine, we need to change our mindset and need to use our machines much more nicely. Thank you. Thank you so much. Dr. Abha, I'm going to be here for the panel as well. Not to worry, I'm going to be here only. Thank you so much.
Thank you for the wonderful, wonderful lecture, Dr. Kuldeep, sir. And we have revised all our basics today. Got plenty of things to now go back to the knobs and implement what you have taught. Because basically we have to just, and anybody who wants to revise this lecture and run the lecture along with the knob settings can please go to the YouTube. For a very long, long time. So, sir, you are recorded for us.
Thank you. Thank you so much. But
Any
it's
comments
just
on-
that we don't need to be really scared of these knobs. We don't need to be scared of the settings. And see, it's always difficult to call back the application expert again and again. They're not going to come. They're going to come once or twice when you buy a machine. Afterwards, you need to be revising them and you need to be playing it. One thing is very, very clear. Please do not worry. I purposefully moved that slide away. Do not be worried if I'm changing the settings, what's going to happen. Nothing till the machine asks you that 3 times. Should I save? Should I save? Should I save? If you haven't done that, you just have to go from one preset to the other. And again, the old settings are back. Use your transabdominal, go to the transvaginal, come back transabdominal. Nothing has been changed. You're not going to be spoiling your machine. Don't worry about that.
Thank you, sir. And as sir says, if anyone can do it, you can do it.
Absolutely.
There's nothing you can do.
That was really,
if you
that
set
was
your
really
mind.
wonderful. Monica, very good.
Yes. So,
Yes,
Dr. Sunita is there. Dr. Sunita would like to comment. She is our chairperson.
Ma'am, she
Sunita.
left due to some emergency.
Okay. Dr. Sujata, you can conclude.
Yeah. That was really wonderful, Dr. Kuldeep. I'm just thinking tomorrow what I'm going to do in front of my machine. I'm going to play again and
Yes.
try all those things and try to remember all those things which I have learned today. Thank you so much. Thank you.
Thank you. Thank you, ma'am. It's a video game, so it's always nice to play with.
And sir, I
Yeah.
would like to confess, when I was your student in Sono School, whole of COVID we did with sir. Whole of COVID we were doing only ultrasound classes. To the extent that as soon as we stopped, the COVID ended, I bought a really nice, fancy, high-end machine, which was, over my budget, but still I bought it because I wanted to do the best. So, sir, I
And
had the
those,
copies. I had copies Sono School 1, Sono School 2, Sono School 3, and Sono School 4. Your lectures were so many that I had to make notes. And we were very excited about the Kahoot quiz because sir used to take a quiz and I wanted to be in the top 10. Then I wanted to be in the top 5, then top 3. So we used to revise your notes. Thank you so much, sir. Now those terms have gone into our brain and settled there.
I'm so glad. Thank you. Thank you so much.
Thank you, sir. And we will trouble you again for more of your talks in the
No
future.
problem. Always there.
Thank you, sir.
And Asha ma'am, I'm here only for the panel also. Don't worry. I'm here, Monica. Right?
Thank you
Thank
so much, sir. Thank you. Because like in COVID, 2019, I somehow crossed one of your programs and I heard that knobology then. And I sat on my machine and started tickling, do this, do that. It's a different machine. I have a G machine, but you get the hang of it, how to actually arrange it. And then go to the sub menu and then go to the sub menu and see what's happening.
It's all there, ma'am, and all our machines are very good. I'll be very honest because it's all there. We just have to use it.
Yeah.
True, sir. So now I think Purva and Nandini, we can move to the panel discussion, much awaited panel discussion.
Yes,
And
ma'am.
all the panelists have been studying very hard for it.
So carrying forward to our exciting panel discussion, I welcome our moderators, Dr. Asha Jain ma'am and Dr. Monica Singh ma'am, and expert Dr. Kuldeep Singh sir.
Would you enumerate the panelists, please?
Yes, ma'am.
yes, ma'am. Can
Asha ma'am, you have to stop share for 1 minute so that the panelists can be just introduced. Yeah, now it's done. Purva, Nandini, go ahead.
Yes,
yes,
ma'am.
ma'am.
Dr.
And we
Vishal.
have the series.
Start
We
with
have a galaxy of
So,
panelists.
we have with us Dr. Asha Jain ma'am and Dr. Monica Singh ma'am as the moderators of the panel. Dr. Asha Jain ma'am, madam is presently chairperson FOXY Food, Drug, Medico and Surgical Equipment Committee, FOXY. Madam is director of SMSA Hospital Raipur, medical director Cancer Prevention and Relief Society, elected member CG Medical Council, president
Dr.
Raipur
Purva, I
Menopause
don't think
Society.
you need to do that. Just display. If you're going to read 15 CVs, it's going to be tough. Just let it display and go on.
Yeah.
Okay, ma'am.
So let us go to the panelists, please. Huh? Yeah. Nandini, just display the CVs. One line, just the
Yes.
name. Just the names.
Yes, ma'am. We have a large group of panelists. Our first panelist is Dr. Anita Rajoria, madam. She's the president of ISOBAP Delhi and president of Delhi Gynae Forum Southwest. Our next panelist is Dr. Anshu Jindal, madam. Madam is director at the General Hospital and Fertility Center at Meerut. Our next panelist, Dr. Archana Srivastava, madam. Madam is currently working at the Sri Siddhi Vinayak Hospital, Sagar. Our next panelist is Dr. T. Chitra, madam. She is currently the secretary of IFS chapter, Pondicherry, and she is affiliated to the esteemed Jipmer Institute, Pondicherry. Our next panelist is Hema Jeshubani, madam. Madam is currently the professor and head of department in Maharani Lakshmibai Medical College. We welcome you, ma'am. Our next panelist is Dr. Jagrati K. Nagar, madam. Madam is president of Sagar Ophthalmic Society and currently working as associate professor in Bundelkhand Medical College. Our next panelist is Dr. Preeti Maheshwari, madam. Madam is the director of Preetank Mother and Surgical Care Center, and she is also working in Arihant Hospital. Our next panelist is Dr. Risha Dhiravani, madam. Madam is currently working as director and consultant at Jabalpur Hospital and Research Center, Jabalpur. We welcome you, ma'am. Our next panelist is Dr. Rupi Reja, madam. Madam has currently working as a consultant in Khemchand Jain Charitable Trust Hospital in Sagar. Our next panelist is Dr. Smita Dubey, madam. Madam is working in Kilkari Hospital in Sagar, and she has been a past secretary and president of in Sagar Ophthalmic Society. Our next panelist is Dr. Sushita Srivastava, madam. Madam is currently working as associate professor in RKM CHRC Hospital. We welcome you, ma'am. Our next panelist is Dr. Varuna Pathak, madam. Madam is currently the professor and head of department in Ramakrishna Medical College, Bhopal, and she has also held various prestigious posts in Bhopal Ophthalmic Society. We welcome you, ma'am. I request our conveners of the program and Asha Jain, ma'am, to move ahead with the panel discussion.
Thank you so much. Thank you, Monica, for this opportunity. And I hope Ganesh ji is going to bless us and our minds are going to be really sharp. We are going to locate the pregnancies in a jiffy. All right. So these are the panelists and this is the Synergy webinar. Sir has taught so much. Would somebody like to comment what this is?
Ma'am, it looks like an early gestational sac, very early gestational sac, because endometrium is thickened, and it also depends on the history of the patient. If the patient having a regular cycles and it comes.
We are just right now, we are talking about what are you seeing here? You see a thick
Yeah, it's like a sac, like you can see a sac-like structure in the endometrial cavity. So
how would you confirm this? How would you confirm this?
Important, you need to ask last menstrual period, ma'am. If last menstrual period is very important. So if at all she tells she has missed the periods just by 5 days or 10 days, you can confirm it can be an early gestation sac. And other things you can tell that I think most important is regular cycles, LMP, no history of any OCP
Do
usage.
a UPT?
Yes, absolutely. That's the
Arsha,
first
there
thing.
is some evidence that this whatever sac-like structure we are seeing is eccentrically placed if one sees along the one wall. So
It is
that
centrally
may
placed.
be, yeah, that may be, an indication that it will evolve into a normal gestation sac as the pregnancy advances.
To see whether the sac is eccentric or not, this has to be an exact mid-sagittal section. So you should be able to see the entire midline.
Cervical canal also, yes.
So if you are not able to see the entire midline, then you cannot comment whether this is eccentric or not.
No.
Yes.
Right?
Yes,
So
Okay, it is
now we
seen,
come to the questions proper. If there is a gestational age discrepancy, how does it impact the diagnosis of a normal intrauterine pregnancy?
So can I take that, Arsha?
Anyone, ma'am.
Yeah.
Welcome.
So first, thank you for the opportunity. We have to, first, confirm at early gestation to know exactly what is going to be the expected date of delivery. Because patient may be having irregular cycles, so we have to decide the exact date of delivery depending upon her history. So it is said that if you are doing early scan and you find that the gestation sac you find is within 7 days of expected from last menstrual period, and it corroborates with that you define EDD according to LMP. But if you find that it is not corroborating, the discrepancy is more than 7 days, then you assign the EDD by ultrasound. Now, this EDD given by ultrasound is very, very important because we are going to follow through the pregnancy depending on this assigned EDD, because it will
Dr.
become
Anita,
important.
this is a very, very early pregnancy, right?
Yes,
And we are right now talking about locating the pregnancy. right?
Ma'am,
So if she is whatever her LMP, if you see a
So it will,
gestational sac inside, if you see a gestational sac inside, then you're going to correlate. Right?
yes,
Yeah.
ma'am.
found now.
So
We have
what
to
are
follow through.
the
Yeah.
key sonographic markers that confirm that it's a normal intrauterine pregnancy? This, the photo that I showed you, it's so early.
Yes,
Do you
very
think
early
that is the
gestation.
right time to say that, yes, this is normal?
No, ma'am, no.
No,
I
we have
think,
to do. Yeah.
So
yes,
normal-
Richa was talking, I
Yes,
think.
so
Richa,
madam, usually transvaginal ultrasound should be the preferred methodology for locating intrauterine pregnancy, early pregnancies. In TVS, we have to look for double decidual sign, as well as usually a normal GSAC is eccentrically located, as you said, and we have to also confirm after doing UPT, beta HCG, whatever is indicated as per history. I look for the double decidual sign in previous ultrasound.
I think for the normal, we have to see for the presence of yolk sac. That is more important, yolk sac. Along with that, if at all fetal polyp with cardiac, yes, it shows a viability. But better than the gestal sac, it's a yolk sac, which might tell it can be a normal intrauterine pregnancy.
Okay.
So the yolk sac is a very, very important structure. Kuldeep sir is with us. Sir, would you like to add something here?
The first indirect sign when you don't even see a gestational sac would be a asymmetric thickening of the endometrium. So if you're looking at a thickened endometrium and you find the anterior, the posterior wall of the endometrium is a little more thicker, that's when that's going to raise a suspicion. It's there where you really need to be looking in for, and if it doesn't displace the cavity, we're going to call that an intradecidual sign. And when it displaces the cavity, that's when we're going to call it a double decidual sac sign.
Yes.
All this happens before 5 weeks, 2 days, 5 weeks, 3 days, when you're not going to be able to see a yolk sac also. The moment you see a yolk sac, then all doubts are kept to rest that it's definitely an intrauterine pregnancy.
Thank you so much, sir. So there is such a thing as a pseudo-gestational sac that you would see sometimes in an ectopic pregnancy. So how do you differentiate a pseudo-gestational sac and a true gestational sac? How would you differentiate that?
Ma'am, actually, the absence of a yolk sac in the first place,
Yes.
the absence of a yolk sac is the loudest sign that will tell you that it is a pseudo-gestational sac. And then the echogenic character of the hypo, it's just the G sac is more regular than a pseudo-gestational sac.
Yes.
Surrounded by a hyperechoic rim, ma'am.
And I think also the location.
And the double decidual reaction that they were talking about, I think that clinches diagnosis of intrauterine pregnancy, real intrauterine pregnancy.
And on putting on Doppler, we can see the vascular reaction, hypervascularity around the gestational sac, which will not be visible in pseudo sacs.
Madam, and initially what sir told or what you told, you should see that all these sacs are usually present eccentrically, whereas pseudo-gestational sac is present only in the center.
Center.
One thing is and the
Exactly
shape
in the
also matters.
center. So it could be just a little bit of fluid in the cavity. So you need to see the echogenicity as well. And then whether it changes shape, with your probe pressure.
Right.
So if the uterus is, it's not exactly anteverted, supposing it's in mid position or it is a retroverted uterus, then how does it impact your imaging?
It has happened sometimes we have missed the pregnancies. We have really missed the pregnancies. We have told it might be UPT, though patient is a UPT is positive, weekly positive. There she has come. I told it might be false positive. You wait for 2 weeks, you come. So many chances when the uterus is especially retroverted, we might have a doubt. It can be an abnormal location of the pregnancies also. Sometimes we have thought it is like cervical pregnancies or in a rudimentary horn. So these are the things we had faced when you're not placing when the uterus is usually tilted.
See, the basic thing that we need to remember is whichever way sir told in his lecture today that we have to orient ourselves with what we are doing. Yes. So we have to get used to a particular proposition and the way we want to place the uterus. So before you comment on anything, you need to see the entire midline. That is a basic thing. whichever way you are seeing it. If you're not able to see the entire midline, then you need to go and do it from above. But when you're doing vaginally, you need to see the entire midline. And if you can see that, and as sir has explained today very well, adjust the focus, increase the size. If you adjust the gain, if you do all that, I don't think the tilting of the uterus is going to have an impact. Okay, because we need to remember the basics. That's it. We need to remember the basics. We've already spoken about the yolk sac. Now this question, when we send our patients for an ultrasound, the radiologist will usually do an abdominal scan. They will rarely do a vaginal scan. So how does an abdominal scan compare to a vaginal scan when you want to diagnose a pregnancy?
TVS is always the preferred mode. We should always request for TVS in early pregnancies, especially in cases where females are obese or wherever you can feel that TVS will give a better magnified imaging. Yes, as you mentioned, none of the radiologists prefer doing TVS. Abdominals is easier sometimes, but I believe with good machines available, even 6-weeker abdominal, transabdominal ultrasound these days is very good. That can be diagnosed with ultrasound, abdominal probe also.
And
Ashwati, somehow I feel
going to miss
somehow I
a very
feel
early
about-
GSAC would be missed on a TAS. A SAC less than, say, like a TVS would pick up a 16 mm SAC, whereas a TAS would minimally require a 25 mm SAC to be able to pick it up. So early ectopic pregnancies can be missed because of that. Early pregnancies, intrauterine can be missed. Wrong diagnosis can be made. So a TVS would always be a preferred modality.
Of course, a preferred, but I just wanted to comment that they are complementary to each other. First survey should be, I think always, radiologists always advise that a good transabdominal also should be done. We are going to look at adnexa also. Means lower pelvics you should see. Transabdominal, of course, TVS is more confirmatory and more diagnostic regarding early pregnancy and associated problems are concerned. But I think it's one
The
must always
resolution
start
is
with
better.
transabdominal and then do TVS along with them.
The other added
resolution of
advantage of
transvaginal is better, ma'am.
transabdominal, other added advantage of transabdominal is gives a broader view, so you can see even the ectopic pregnancy or any fibroid or any cyst, along with which we can miss in transvaginal ultrasound.
Yeah.
So as Madam told, it can be complementary. Both can be done so that you don't miss anything.
So now I'm telling you, when you are in your OPD, when you have a patient, you've treated her, she's come for a UPT positive, right? Now you are examining her uterus. You have seen that there is a pregnancy. You've seen a yolk sac inside the uterus. Is that the end, or you want to do something more?
Ma'am, we like to even to
It's
see
a
the
topic pregnancy, ma'am, so you have to pull out the adnexal.
adnexal also we
as
should see,
well.
ma'am. Because
So-
first time is the
Though it
scan
is
is the
rare,
best time
but
to
it
rule
can
out
still
any.
happen.
Yeah, first time is the scan is the best time to rule out any uterine anomalies, adnexal pathology. So as a gestation course, we might miss it. So we have to look for other pathologies along with the first trimester ultrasound.
And heterotypic pregnancy, ma'am, it can be double. It can be both intrauterine and extrauterine, though it's rare. But with IVF, we do get heterotypic pregnancies also. Heterotopic.
Correct.
So that's not the end of the story if you just see an intrauterine sac. You have to be sure of the adnexa.
Exactly. Because see, I had a patient 15 days back. She was sent to me to do a DNC for retained products after medical abortion. She
Right.
was carrying an abdominal ultrasound. I asked her that I want to do the scan myself. She said, "No, this is here. I've already paid for it. I don't want again." Because her beta HCG was 25 something, and I could see nothing on the scan, I gave her methotrexate. Okay. Yesterday she came. She actually had a right ovarian pregnancy.
DNX is very important.
So, and it had collapsed luckily, and the ring was gone, but I could still see, the collapsed sac and everything. So we have to, which side the corpus luteum is on, and we have to see both the tubes and ovaries as much as possible. seeing the healthy pregnancy inside the uterus doesn't end anything.
And here, very true.
Now, this is another case. Dr. Monica, you want to take this? This is the uterus and this is the lower uterine segment, right?
Right.
No, ma'am.
So, this is a pregnancy which is not implanted in the fundus. It's implanted in the lower uterine, but not in the cervix. It's in the lower segment. So it's such an early pregnancy. How would you differentiate that this is placenta previa or it is a low-lying pregnancy?
Ma'am, usually in first trimester, we cannot tell it is a placenta previa. We have to see the length of this edge of the placenta of the cervical internal os. Most of the time, because of the uterine migration, the placenta can migrate up. So, provided up till 20 weeks, if you find the edge of placenta is covering the internal os or near the os, there's chances that shown that at least 15-20% of this can go into placenta previa. So that's a thing we have to tell the patient when counsel the patient whether there's a
this is
No,
an
ma'am,
early
this is
pregnancy.
early pregnancy. So you can see the placenta forming, the decidual reaction, what you call. You can see it coming down, covering the internal, coming right up to the internal os. That's how you know that this patient might land up with a low-lying placenta or something like placenta previa also. So you can just give an indication and it's visible more after 10, 11 weeks of pregnancy.
Yeah,
Because otherwise the placental reaction is all around in the
Yeah,
beginning.
actually, Anshu is right. The placentation actually starts being seen distinctly after 11 weeks.
Yeah.
That is when the luteoplacental shift also occurs. And I think all gestation, all these low-lying chorionic reaction and the placental tissue which is forming should be just called low-lying. There is pretty high chance
And
of
not placenta previa.
Yeah, very few of them will actually continue to cover the internal os. Varuna, you're muted. Varuna, you're
Yes,
muted.
correct.
Yeah.
So in such a patient, early pregnancy, maybe she's now at 12 weeks. Do you want to measure her placenta, her cervix?
Yes, ma'am, that's important. It will not only for the placenta previa, it also predicts the chances
all
of
the cases
preterm
they should-
labor or second trimester abortions and the relation
Whether
of
she
this.
needs a stitch, ma'am, whether she needs a
Yeah.
stitch, because
Yeah.
usually at 14 weeks, we give that McDonald stitch. So I think 12 weeks, it's a good time to start measuring the
Another
cervix.
thing is that if it is too short a cervix, it is sometimes spuriously appearing as a low-lying placenta, but it may not necessarily be. Like a short cervix can give the feel of a low-lying placenta.
No, this is, we are talking of just early implantation. What is the best way to identify the placenta when you're doing a 10-12 week scan? How do you identify the placenta?
Ma'am, transvaginal ultrasound is the best, ma'am.
Ma'am,
Ma'am,
it's
you can
around
see the
round
sonographic-
mound-like structure with vascularity with the central cord insertion point, and we can put on the Doppler to look for the vascularity, which is very much increased around that structure. It's a homogeneous echo texture. That's all.
It's very apparent, ma'am, after 10 weeks, the placenta formation is very apparent when you do it on early ultrasound.
Yes.
True.
So, a very easy way that I do is take a 3D and you'll see that entire disc, kahan se kahan tak ja raha hai. You're able to see it so well.
True, ma'am, correct.
And you can see both the insertions into the abdomen and also into the placenta. You have the entire thing visible before your eyes, half a minute spent.
And I think early pregnancy Dopplers are not to be encouraged. Try to
No,
avoid.
I'm talking about 10 to 12 weeks.
Yeah, ma'am.
That's what I said, 10 to 12 weeks. After
Yeah.
10 weeks, you do Dopplers.
Yes.
So if the patient, you're doing an abdominal scan and the patient has a BMI of 40, right? Quite common these days.
This is so. That's
So what is the difficulty and how do you actually get over that difficulty?
Yeah, it can be challenging, image resolution is going to be very poor. You will not be able to locate where is placenta, cervix, because resolution is really difficult, and shadowing attenuation is always there because of this. And we sometimes are not able to relate what is the relation of cervix with the placenta lower edge, as she was talking about, Ashaji was talking about. And maternal obesity can itself distort the uterine anatomy also. So it will become difficult to again locate gestation sac, especially in early pregnancy. So
Ma'am,
the
the full
strategies will be,
bladder.
as sir told me in his lecture,
Yeah.
that you use high frequency transducers for better image resolution in such patients, for better depth penetration, or you can use
You
TVA,
have to
TVS, or
use low frequency, high penetration.
Yes.
yeah.
You need low frequency and high penetration, and then use all the tricks. Your area of interest has to be magnified. It has to be zoomed.
Angulation should be good.
And full
And
bladder,
one
ma'am,
more
full
thing, as
bladder. Full
obstetricians,
bladder.
what we should know, that the bikini mark on the abdomen is where there is almost no fat, irrespective of how fat the woman is. So always use that area to put your transducer.
Right, true, ma'am.
Madam, angulation is to be
Full bladder,
only
full
over the
bladder. And
pubic
transvaginal,
area.
if you're not able to see transabdominal, you can always use the transvaginal
Yeah.
probe.
You can do the transvaginal, but if you're trying to do a transabdominal, that
Right,
bikini scar is the area where you're going to put your probe, and whatever the BMI, I have done up to 120 kg. You can still see.
Yeah, I would
You
agree.
can still see.
A little tip from my side is that sometimes in this very obese, flabby abdomen, I tell the woman to put a slight bit of tug just below the umbilicus. She pulls that pad of fat
Yeah.
away from the bikini.
I do
Sometimes we tell the assistants also who are standing next to them to pull the abdominal fat more towards the caudal region, cranial region, so that we have a
That is
beautiful
more
plane and this.
effective for the mid-trimester anomaly scan. But right now, this is a patient in her early pregnancy. So in early pregnancy, you just put the transducer. Now, the angle of the ultrasound, as an obstetrician, when I started ultrasound, this is what I found most difficult. This is the tip, and this is how the rays are going. And so it's a section that is being cut that we are seeing. So what you see, how is the angle affecting it?
As you told, madam, always
You
you
have
should
to
have a
adjust, ma'am.
sagittal plane.
You have to keep
To have a
adjusting
better
to
view,
the right.
sagittal plane, you should follow it properly. Then only we'll be able to locate the pregnancy, the location, the cardiac activity. If the angulation is wrong, we won't be able to properly report the findings.
It just happens automatically, ma'am. You keep changing the angle when you put the probe and you get the right
Exactly. When
thing.
you're doing it, your hands
yeah.
automatically do it.
Yeah, absolutely.
I'll
You don't
give
even
you a
calculate,
small-
it's so spinal.
I'll give you a small tip from embryo transfer that we do, Anshu. Unless it is a perfect mid-sag, you'll not be able to see the ET catheter, nor will you be able to see the transfer bubbles.
Absolutely.
So that angle is very important for us during embryo transfer.
So, but the tilt has to be there. You have to tilt
Yes.
the probe accordingly.
So sometimes the uterus is so much deviated, you have to tilt. You have to, in fact, tell your assistant. During embryo transfer, you cannot hold the probe also. So you're
Yeah,
totally dependent on your assistant to show the angle and everything.
Can I
Kuldeep
just
sir,
add 2
would
points?
you like to just give a few final points for this case before we go to the next?
Sorry, ma'am. Was it for me?
Yes, sir.
Yeah,
Yes, sir.
there were 2-3 points which I wanted to say. One, never overfill the bladder, just to get in so that in a transabdominal we can see it nicely. Never overfill the bladder. Plus, now when the summers are coming, there'll be plenty of patients who will have lots of powder in that area, especially the Bickley line area. So you need to be very, very careful that you need to first tell them to either wipe it with a wet tissue or something, because there'll be air trapped between and you'll be getting a very coarse, inhomogeneous image. So that's the other point you need to be careful. The other very good window that you can see, especially with obese patients, though at 12 to 13 weeks, if the bladder is nice and full, through the umbilicus, you can see it nicely. So the bikini portion is always there. You can always retract, or from the sides you can see it. Sometimes the NT portion, especially in the obese patients, the problem is you can't do a transvaginal scan to look in at the NT plenty of times if the baby's position is not good. Then you need to go onto the side and then see it. Those are the only few tricks and tips that you need to do.
Thank you, sir. Thank you so much. Dr. Monica, you want to take the next case?
Yes, ma'am.
So this is the image for you. The new complication that is happening post cesarean sections.
In fact, I
This is-
like, yeah, it's a cervical pregnancy.
This
or
is
it's
a cervical pregnancy.
So, cervical pregnancy has got two important different diagnosis.
Ask the questions, my dear. You ask the questions.
Yeah. So, what are the sonographic features which are diagnostic of a cervical pregnancy? Define a cervical pregnancy, and what are the differential diagnosis of a cervical pregnancy?
And
A
I
true-
would like to take this question.
Please.
Can I?
Yeah, please.
Cervical pregnancy itself is a rare entity. It's almost 1% of all the ectopic pregnancies.
1%.
Here, the sonography feature that will confirm that, that will say that it is cervical is we will see the uterine cavity is empty and the pregnancy G-sac is located in the cervix. The main
Below the
thing that will
uterines.
differentiate below the internal os.
Below
The cervix is barrel-shaped cervix, or we can also say it's an hourglass uterus because upper cavity is empty and the cervix is barrel-shaped. So it gives an hourglass appearance also. And to say that it is cervical pregnancy, either we should visualize yolk sac or the cardiac activity should be present. Because the main differential diagnosis is like miscarriage. Because in case of miscarriage also we can see the sac coming inside the cervix and we can confuse it with the cervical pregnancy.
What is the status of the internal os? What is the
Internal os is closed in case of cervical pregnancy.
Other thing, ma'am. Yeah. The uterine cavity will
Uterine
be
arteries
usually
enter,
empty.
where the uterine
Uterine
arteries
cavity will
enter.
be
That's the
empty
area of the
in
internal os.
uterine cavity will be empty in cases of cervical pregnancy, and there will
Yes,
be
ma'am.
increased vascularity in the cervical area. It shows an increased vascularity, and when you
have
see
to put on
even the
color
myometrium, no,
also.
it's very thin.
So the cervical pregnancy will have the complete chorionic reaction, the complete ring situated below the internal os in the cervical canal,
Absolutely.
causing a typical barreling or that bulge in the cervical region. It is pretty rare, less than 1% or 1%, the total number of ectopics. It's an important DD, but
What is
having
the role
that-
of Doppler?
Yeah,
What is the role of Doppler?
over here.
The Doppler will delineate it very well, ma'am. You can see the residual reaction, you can see the blood flow.
And it will,
since
madam, it will help to differentiate between the this inevitable
Miscarriage
abortion
and-
from the cervical pregnancy. The
That is
Doppler, because
one. And the other thing is when you're calling it cervical, then the insertion of the uterine artery, when you're doing the entry of the uterine artery, which we see in the first trimester scan, your pregnancy will be below that.
Yeah, absolutely.
Your pregnancy will
Correct.
be below the uterine arteries.
Yeah.
Correct. Yeah.
So there are definite criteria for diagnosis of cervical pregnancy. There are 3-4 criteria which are very important.
Rubin's criteria. Rubin's criteria.
The internal os is very much dilated in incomplete abortions. You know, you will see a wide open internal os. The whole pregnancy has simply plopped down. And of course, in the uterine cavity, you will see that ragged endometrium, because a shaggy endometrium in the fundal region signifies that the pregnancy is in the process of aborting. It was actually an intrauterine pregnancy. The symptoms also correlate. In incomplete abortion, she will have more of that bleeding and the symptoms, passage of clots, the typical dilated internal os. And cervical pregnancy will have the complete gestational sac in the cervical canal. The bleeding might not be that significant. The pain factor would be more. Yeah, the pain might be equal in both. It might be very painful in the incomplete abortion. And now you are putting a 3D and trying to confirm your diagnosis. How does 3D help you in confirming the diagnosis of a cervical pregnancy?
So it helps us to have a
Blood flow
good
will be
visualization
typical.
and differentiation, ma'am. Very good. I mean, 3D will tell you the properly the location, the differentiation between the sometimes you might have an abortion like what inactive abortion, or it can be in polyp, it can be hyperconjugate area. You can see the blood vessels. So it helps us to better to give us a little bit of
The blood
differentiation
flow
and
will dictate in a cervical pregnancy, you'll be able to see the blood flow all along the sac. And it's the
blood
typical,
changes.
you can see it's an intrauterine pregnancy, whereas in a retained products or products which are coming down, the blood flow signals are going to be very weak. And it's not going to be in a peripheral circular.
And that,
Very
yeah.
impact the back
Yeah.
end. Now, another DD could be you might be confused now in this era of increased rate
Cervical
of
polyp. It could
C-section.
be cervical polyp also.
Cesarean scar pregnancy.
Might have an endophytically growing scar pregnancy.
Cesarean scar pregnancy.
That
can
is our next case.
confuse
That
with
is
the
our
cervical.
next case. That is
Okay,
our
ma'am.
next
Okay.
case.
So I think, ma'am, Kuldeep sir can finish this case with his comments now.
The moment, exactly what you've all been saying is, if you see a cardiac activity below the internal os, it's done that it's a cervical pregnancy. You move your probe, and if you find that the shape of the gestational sac is changing, that would be an abortion in process. Otherwise, it's definitely a cervical pregnancy. The same thing that everybody said, that around the gestational sac, you'll see vascularity. In abortion in process, you'll not see vascularity.
Yes. Thank you, sir.
Thank you, sir.
So this is our next case. Anybody wants to describe what they are seeing?
We can see the scar very well.
Yes.
And good endometrium and something like a cystic structure near the scar.
So
And
could
the
this
sac-
be a
Increased
cervical,
vascularity. Increased
Uske andar
vascularity
cervical
also.
scar pregnancy?
It
A
shows a
cesarean
gestational
scar
sac
pregnancy.
which is embedded in the myometrium, madam. It is almost embedded into the myometrium.
So
And
it's a
there is,
cesarean scar pregnancy.
yeah.
So how do we
So-
differentiate? Characteristic is, ma'am, there has to be a history of a C-section, first of all. That's most
Yeah.
important.
Yes.
And then it is seen it is seen at the level of the previous cesarean scar. It is seen embedding into the scar with a uterine cavity which is empty and a cervical canal also which is empty. Though it can be it is further classified into type 1 and type 2. The type 1s are more growing towards the uterine cavity. Yet there has to be, the myometrial connection between the the hypoechoic area of the G-sac, the fluid of the G-sac, and the bladder is usually in the range of between 1 to 3 millimeters
Correct.
to start with. So that's how you would want to classify it as a
So that
cesarean scar
means
pregnancy.
the way you have described, naturally, it is very different from a low-lying anterior placenta, because
Yeah.
in an anterior placenta, that myometrium thing isn't there. It's a normal myometrium, right?
Right.
Yeah.
So if the scar, people stitch their cesareans in different ways, single layer, double layer, and then sometimes intermittent, sometimes burying, sometimes not burying.
Yeah.
So the appearance of the
Ma'am, locking is the biggest culprit coming up. You don't lock the cesarean scars.
So, but people lock.
Yeah,
Yes,
I've
people
seen
do.
first layer to everyone locks, madam. Only second layer they might not lock, but first layer is
No,
always
no.
locking.
Homeostasis.
Right.
Homeostasis.
What I found the biggest culprit, Varuna, was, which we also did last 10 years, this is a single layer suturing. Single layer also leads to a lot of isthmosia.
So
Single layer does leads to that. But Monica, a lot of literature search that I did recently and comes up is that anything you do which strangulates your incision line, locking, too tight stitching, and poor approximation. Actually, the single layer thing eventually, when the decidua gives away, the end-to-end, the coaptation ratio, as they say, that goes very poor because of the single layer. So even if one is doing a double layer, which is all standard now recommendations are for double layer, you are not supposed to strangulate it. And the locking sutures are now known to cause ischemia, because hypoxia, they say, is the biggest driver. What comes up is that if the cesarean scar has become hypoxic, It is the anterior abdominal wall, the peritoneum, the bladder. Everybody wants to. It comes up as a a vascular graft.
Dr.
That
Varuna,
leads to the
that
formation of
is a
adhesion
topic for
and pulling.
another day.
Yes,
That is
yes,
a
yes, ma'am.
topic
Yes,
for
ma'am.
another day.
Yes,
Right
ma'am.
now,
Yes,
what
ma'am.
we are
Yes,
talking
ma'am.
about is that scar might give away in its entirety,
Yes.
or at
Yes,
its
ma'am.
angles, or in the middle. So the orientation every time is different. When you're doing an ultrasound, you're basically just going through a section. So when you are seeing that, ruling out or diagnosing cesarean scar pregnancy, we have been harping so much on that mid-sagittal section. Yes, we take the mid-sagittal section, but is that all we take? Or we move through the entire thickness of the uterus, left to right, top to bottom?
And
What
transfer.
what is your say?
Absolutely, ma'am.
Ma'am, you
Yeah.
have to go through the entire what you're telling, not only one plane, because you need to confirm it. So you have to go through
Yes.
all the plane, not only sagittal plane.
So every patient, when you're doing a scan to diagnose an intrauterine pregnancy, yes, well and good, you need a midline section, but you need to see the entire uterus, right? Now,
Yes,
in cesarean scars pregnancies, what is the color Doppler finding which actually terrifies us?
Ma'am, it will tell us usually in patients with cesarean scar pregnancy, there'll be intense vascularity will be there because the myometrium is thin and always the sac is into the myometrium, so the vascularity will be more compared
And
to
the uterine artery is right there.
right nearby. Yes, high resistance
So,
flow also will be
so
set.
basically, where the placentation is, whether it is going to touch the uterine arteries
And the bladder, ma'am, and the bladder also.
and the bladder.
Yeah, that is what terrifies us.
So, what are the pitfalls when we are trying to diagnose a cesarean pregnancy? I think this question goes directly to Sir.
What we really always need to be careful is that is that a true gestational sac or is just an isthmocele which we're getting confused with? That's something where the moment we're looking at a fluid and we say that. The other thing is if we're looking for an exogenic or an endogenic, sometimes there's just a mass over there and we're not sure whether is it a cesarean pregnancy or it's just something else over there. So you need to be looking at the patient's history, the beta HCG, and planning it, whether it's going to be going a little out or it's going to be coming inside.
Okay. And depending on the gestational age, do the ultrasound findings differ? In early pregnancy, like compared to 6 weeks to 12 weeks, do the findings differ?
Yes, ma'am. I think early gestations, the sac is small, so might be it is very difficult to differentiate also whether it's cesarean scar pregnancy or sometimes it can be delayed. Sometimes it can look like a Nabothian cyst. So I think we need to wait for at least 2 weeks from that and confirm it can be an cesarean scar pregnancy.
Whether it is embedding into the myometrium, ma'am, because as it advances, it can go deeper into the myometrium, it can invade the urinary bladder, and the uterines are nearby. So as it becomes bigger, I think it becomes more dangerous looking. It can
Sometimes
be
through
more
type
dangerous.
type A cesarean scar pregnancy, sometimes it may grow upward also.
Yep.
So a serial scanning is
Migration
also
can
important to migration can occur. So it's this time the serial ultrasound can help us to finally label it as cesarean scar pregnancy, or it may migrate up also.
3D ultrasound is very useful in documentation of cesarean scar pregnancy, ma'am. It is very good. It will be able to tell us how much depth it has gone into the myometrium.
But the pregnancy.
Sir, can I ask you a question?
Sorry.
Sir, how do we like figure out whether this will proceed to like an MAS, the morbidly adherent placenta?
The one that is migrating, that's what I was saying. That's almost sure that it's going to have a low-lying placenta, and most likely it's going to have a PAS placenta accreta spectrum is definitely going to be there. So we need to be very watchful for that, and that has to start not only from 6 to 8 weeks when we're going to be diagnosing it. At 12 weeks, you need to be carefully looking at the retroplacental vascularity. You need to start looking at the lakes over there, whether there are vascular channels or not. So, and you have to give that prognosis to the patient also that might be we'll have to terminate it earlier also.
Earlier you terminated it, the better it is.
Yep.
It's to be terminated early. Because it can
Some
become
of them
very
might
bad
say,
as
we're
it
going to carry
advances.
on, but then we know that has to be with a pinch of salt. 28 weeks, 30 weeks, or might be at 16 weeks when we see there's major problem coming up. We tell them, no, we'll have to really not continue further.
Nowadays, they are even
Yes.
injecting methotrexate right into the pregnancy to
True, correct.
that it becomes resolves there only.
The earlier ones, but then one is seeing quite a few times that we need to be doing that, plus going through laparoscopy plus hysteroscopy.
Laparoscopy if it is advanced. Yeah.
Both the things.
And very many of these ectopics are also failing ectopics. So if you follow up the ectopic pregnancy with serial beta HCG, sometimes I've even seen like without the methotrexate injection, a few of them are just, disappear. But it requires very careful follow-up. That
But
comes
then that's a good idea to give them a methotrexate dose before.
you can,
So that,
but
you are at least
I've
Yeah.
seen tubal ectopics disappearing. I mean, one of my patients, she was due for methotrexate. She did not turn up, very low socioeconomic status. She came from the slums. I saw distinctly a gestational sac in the tube. I warned her, I called her again. I told her to go to a government hospital. She did not go anywhere. She comes to me after 2 weeks and the sac has disappeared.
Ma'am, you're telling about cesarean scar,
a
ma'am?
lot of surprises.
I'm
in
talking about the tubal
obstetrics.
ectopic. Very
There's
easily
a lot of
visible.
surprises, Monica, but you can't really depend on
No,
that
you can't,
because
you
that
can't.
can be
Yeah.
very dangerous also.
And methotrexate is a good drug. All
Yeah.
said and done,
Yeah,
like
yeah, man. We give methotrexate for all unruptured ectopic pregnancies, and it has 96% it has resolved.
But sometimes you have to give 2 or 3 doses also, not just one. dose.
Multiple dose. No, we'll see, madam. We'll repeat it. Depends on the beta HCG levels. If beta HCG levels are less than 5,000, we'll give only one dose. Okay. Provided patient is stable, everything. If beta HCG levels are more, we'll go for the multiple doses. Provided patient is stable. All this matters.
Yeah.
So now we come to the next case. Monica, how much time do we have?
Ma'am, we have 20-25 minutes. Actually, we have 4 hours because from ICOG we get 4 hours, but you can finish the panel easily, ma'am. No problem.
So what is this?
Yes, ma'am. It looks like an ectopic. You can see the uterus. You can see the sac in through the lateral of the uterus. This is a I'm showing the cursor here. This is endometrial thickness.
Commonest ectopic.
Okay. So how
Yeah.
do you diagnose a tubal pregnancy?
When you see for the gestational sac placement, it will be usually outside the uterine cavity. You can see the tubal ring sign, and sometimes you see the uterus cavity is empty. There can be echogenic free fluid, can be there, minimal free fluid in the pouch of Douglas, and you can see sometimes
Means
you can
how
see
do
when
you
the,
know if
the
you do not see the yolk sac? How do you know it's not a corpus luteum?
Ma'am, corpus luteum usually there'll be ring of fire sign will be present in both the patients, but corpus luteum placement is always in the ovary, whereas this ectopic pregnancy will be outside the ovary. That's the most important thing. We'll have a differential diagnosis. The ring of fire.
How will you diagnose that?
Ma'am,
What
the ring.
movement on ultrasound are you going to do to differentiate that this is in the tube and it's not in the ovary?
Ma'am, a sliding sign?
Sliding sign.
Exactly.
Sliding sign.
You'll do a sliding sign.
It will be positive in cases of ectopic pregnancy, whereas it will be negative in cases of corpus luteum. Madam, one more thing, that corpus luteum, if you see the walls, no ma'am, it usually will be irregular thin, whereas in cases of ectopic pregnancy, usually will be thick, echogenic, when you have to differentiate between corpus luteal cyst and ectopic pregnancy.
And
So if the patient has had recanalization maybe, or there is scarring of her tube, and then she gets an ectopic in that scarred tube, is there a challenge in diagnosing it, or it remains the same?
It will be challenging, ma'am. Because scar tube, no, they won't be having vascularity. You might not see the ring of fire in this thing. So it will be a little bit difficult to diagnose ectopic pregnancy in this thing.
Not be elicitable. The sliding sign is also difficult to elicit if the tube is scarred.
Yes.
And peritubal adhesions also will be there, which might be masking the ectopic pregnancy.
So the tube is rigid. So the chances of its rupturing are much higher that way.
And early ectopics can be missed.
Which tubal pregnancy advanced to the largest gestational age and which
Ampullary.
Ampullary. It has gone till 12 weeks.
Which rupture the earliest?
Is the MIC?
Ischemic
Is
and
6
the
weeks.
mix?
6 weeks.
6 weeks is the mix.
yeah, and even interstitial can go very large.
Yeah.
Yeah, because it has a tendency to go towards uterus as well.
So there is very good definition of Cornwall pregnancy, which Dr. Kuldeep Singh always taught us. Sir, I would like you to define Cornwall for us. Please define for us the Cornwall pregnancy, angular pregnancy, interstitial. 3 terms which are very confusing.
In terms of what we earlier used to think of as interstitial is now the Cornwall pregnancy one. I'm just going to explain that. The angular pregnancy is there in the uterus, but you can see an endometrium lateral to it, and you can see a more than 5 millimeter thick myometrium lateral to the gestational sac. Easier said than done. 3Ds are always better, but again, you always have to have the suspicion on a 2D. Don't straight away go in for that 3D is the ultimate. Then for an interstitial, it's basically the myometrial portion of the tube. That's where the pregnancy is. So you're going to find the line sign where you're going to see the endometrium finish, then a thin line, then you're going to be looking at a gestational sac, and the myometrium lateral to it is going to be less than 5 millimeters. The new definition for the past few years for Cornwall is fundal implantation in a septate or a bicornuate uterus of a gestational sac, either sides, is a Cornwall pregnancy.
So, sir, Cornwall pregnancy term is no longer to be used?
No, we use it for that. The moment we have it in a septate uterus or in a bicornuate uterus, we call it a Cornwall pregnancy.
Right. And even in the rudimentary horn of a
In the
bicornuate.
rudimentary horn also, but we need to explain that. What type of a uterus are we looking at? And these are the findings. And if there's a pregnancy in the rudimentary horn, then we need to be even more skeptical and careful.
Yes, and the interstitial line sign is something which I would urge all my panelists to read, because it's a very important sign. We took a long time understanding it, seeing all the images, seeing our lectures. So this is a thin line between where the endometrium ends and the gestational sac begins. And the myometrium lateral to interstitial pregnancy is thinner than the myometrium in an angular or a Cornwall pregnancy. So I think, Asha ma'am, we can now continue with the questions.
So, what are the errors that we make in diagnosing a pregnancy? We make mistakes, no?
First of all, ma'am, you should be doing a transvaginal to diagnose rather than doing a transabdominal, because you can miss it on transabdominal. And you should always look for fluid also in the pouch of Douglas or fluid around the adnexa, because that will tell you whether it's ruptured or not ruptured. Sometimes you see very big chronic ectopics, when there is a big lot of tissue around it and the hematoma around it, blood clots around it. So it becomes a very big mass in the adnexa. And then you don't see the yolk sac and the cardiac activity, just like a mass in the echogenic or a mixed echogenic mass in the adnexa. So that sometimes it's chronic ectopic pregnancy. So you have to be you have to have a line of suspicion all in your mind before you can, otherwise you can sometimes miss ectopic pregnancy, especially early ectopics.
Yes, chronic ectopic.
And sometimes even the corpus luteal cyst also can be, ectopic pregnancy can be missed as a corpus luteal cyst also. Many times it happens, especially in patient with IVF comes, you should not be happy only seeing the intrauterine pregnancy. We have to check for the tubes also. So in those cases, you might miss the heterotopic pregnancies.
And ma'am, sometimes we can actually over jump on a diagnosis of you don't see a gestational sac intrauterine, you presume it's an ectopic, or you confuse a pseudo gestational sac for it to be an intrauterine, whereas actually this was an ectopic pregnancy.
A chronic ectopic, we should also be careful. Like Anshu said very rightly, it forms such a heterogeneous mass. The Doppler findings are confusing. The beta HCG might not rise. It may be negative also in old chronic ectopics. The LMP is not corroborating. So basically, chronic ectopic requires a very sharp clinical acumen, your ultrasound symptoms, patient's examination, and then take the risk and put a scope there, I think.
And sometimes I have seen that patient has been given MTP kit before, thinking it's an intrauterine, early intrauterine pregnancy, which was not visible, but actually it was a chronic ectopic. And patient comes back for a repeat scan after 10 to 14 days, and you realize, oh my God, this was not an intrauterine anyway. It was a it has become a chronic ectopic.
Yes, the
So we have
MTP
just-
kits are again a big nuisance because people are
Yeah.
not taking scans, none getting scans done, and every girl is taking MTP kit over the counter.
Yeah,
So they are
absolutely.
taking, before doing scan, they are taking the kit. They are not following it up with a repeat scan. So all these complications are happening and they are.
See, Dr. Monica, what I would like to add here is that Foxy needs to do advocacy with the government because the government does not mandate an ultrasound before taking the pill.
So this can
It is not there in the mandate to have an ultrasound before a DNC or an medical abortion.
Madam, it should
So-
be made as important as PCPNDT.
I totally agree, but the situation is as this stands. So
Ma'am, but
this
you
is
know-
something that needs to be done.
Ma'am, there is a clause there that, of course, I completely agree that doing a scan before prescribing the pill is not at all mandatory, but doing a PV is mandatory before prescribing a pill.
But what
An
will you do?
internal examination.
Ma'am, pelvic exam
Mandate-
she cannot make out. We won't be able to
Very early
differentiate
gestation.
early gestation.
Agreed. I do agree. But still, you never know. The vice versa of it may be true. You may be able to diagnose. Ma'am, the vice versa of it may be true.
Okay.
Over the
So
counter,
I'm
it
talking
should
about
not be
the
given.
MTP Act.
So
MTP
now
I'm
let
talking
us
about
be given
proceed.
over the
Now
counter.
let us proceed. Is there a role of serial ultrasound in diagnosing a tubal ectopic?
100%, ma'am.
Absolutely.
100%. We have to, if you don't see intrauterine sac, you cannot tell it can be, you have to do repeat after 2 or 3 days. Concurrently, you can do beta HCG levels also along this patient. You have to see whether it's a doubling time is occurring or not. Even doubling time occurs, we are not sure it can be an ectopic also, but we need to do serial ultrasound until we confirm it is an ectopic pregnancy and the location of the pregnancy is very important.
Okay. So back to sir. Sir, if in this case you would like to add something before we proceed to the next.
See, for a tubal ectopic, ma'am, we have these two signs. One is the bagel sign, where you're going to be looking at a gestational sac, yolk sac, or an embryo, or you can just sometimes see a mass, which is the blob sign. But if the patient is not bleeding, if the patient has crossed the discriminatory zone more than 2000 or more than 1500 on a transvaginal scan, presume it's an ectopic if you don't see an intrauterine, unless and until proved otherwise.
That's very important. That's very extremely important. 1500. I think we should all remember this.
Because the thing is, if you're not seeing a gestational sac inside, and if you're not able to see it outside, you need to inform the patient. You need to tell her, if you suffer from any of these things, quickly come back. And then you need to be repeating a scan every 72 hours or 48 hours.
Basically, you should be able to see a gestational sac with beta HCG as low as 1000. 1000 with 1000, you can see a good gestational sac because we do it regularly for our IVF patients. So it's it's very easily seen. A G sac with a 1000, though you might not see a yolk sac. The yolk sac appears later in the chronology of early pregnancy.
Yeah, I would agree.
So now we are on this case. This is an ovarian cyst. Okay. And here is the gestational sac. What is this image actually telling you?
It might be a ovarian pregnancy.
No, it's an ovarian pregnancy. But if you are the one with the probe in your hand, what is this telling you?
It is a corpus luteal cyst.
This image is telling you that if you see a corpus luteum cyst, don't stop
It can be a
there.
node.
Don't stop there. See the substance of the rest of the ovary. Because here you see the cyst, and outside that cyst is this gestational sac, which is absent
Very
everywhere
rare.
else.
Ma'am, but
ma'am.
just per
I
se,
agree it is rare, but the thing
Yeah.
is, the patient doesn't have it written on her head what she has. So you need to examine every patient thoroughly. So
Yeah.
when you, why are we discussing this? It's a simple TVS scan that people would take half a minute to do. But you're not supposed to do it in half a minute. You're supposed to see the whole uterus left to right, below upwards, and both the ovaries and tubes through and through. You walk through the entire pelvis. That is what this is telling you. Now we come to the nitty-gritty. What are the diagnostic features of an ovarian pregnancy?
Ma'am, usually if there is an sac should be present in the ovary, there should be no connection from the ovary to the fallopian tubes. And with the sac, you might have to see the yolk sac. There'll be increased vascularity in the color Doppler when you see within the ovary. And most of the time, if it is a corpus luteus, it's confirmation it can be an ovarian pregnancy.
Now, an ovarian pregnancy and ovarian torsion. In both, you will see more blood supply in the ovary, right? How are you going to differentiate?
Ovarian torsion is basically an enlarged ovary with edematous appearance, and there would be twisting of the in the peripheral pedicle because of that vasculature. So whirlpool appearance, we would be able to see the whirlpool appearance. That would be the diagnostic of ovarian torsion.
And the follicles that are seen in the ovary, you would see the follicular ring sign. All the follicles would have peripheral edema. They look more prominent. That is what you see in a torsion, which you would not see in a pregnancy. You would see increased vascularity, but it would be that gestational sac and around it. Okay. Now, this is a question that I've put in, jiska answer mujhe bhi nahi malum. The use of morphological indexing for diagnosing ovarian pregnancy.
I think it goes in Spiegel criteria, no ma'am. I thought morphological index means a criteria to diagnose ovarian pregnancy, presence of sac in the ovary. And if you do the surgery, it should show the ovarian tissue, and there should be no connection between the ovary and the tubes.
Actually, morphological
and there is
index
an increased vascular flow.
caters to two parts of it. You know, the heterogeneous mass with the sac inside and definite of an ovarian structure, and then to added to it is the color flow. The color
Increased
flow,
vascular flow.
the vascularity.
So what are the pitfalls here when you're diagnosing an ovarian pregnancy?
The main thing is a corpus luteum cyst, ma'am. You really notice it's a corpus luteum cyst. Sometimes
and a tubal pregnancy misdiagnosed as an ovarian.
Yes, it can.
And even when the ovarian pregnancy rupture, also we might think it is a ovarian cyst rupture unless we do laparotomy and send the histopathology.
And you know, Chitra, we should always think common things first. Ovarian should be the last thing which comes into your mind. Don't ignore it completely. But
a corpus luteum rupture, ma'am, I have a corpus luteum rupture with hemorrhage. Yeah.
True, correct, ma'am. Correct.
Will mimic so much an ovarian pregnancy.
Yeah, agree.
Now this patient has an adnexal mass, coexisting adnexal mass. Then how is the diagnosis difficult?
I think again, I feel you have to go for the vascularity, ma'am. See for the vascularity, see for the presence of the free fluid, and you have to see for
Basically, you should get the correct plane, because supposing
Yeah.
it's a dermoid and it has so many contents, your rays are not passing through only.
Yeah.
So utilize the abdominal and the vaginal scan to get the best possible images. And then the principles remain the same. So we've discussed this. If sir wants to add something before we go to the next.
Remember, the only pitfall is if there's a stimulated ovary and you're looking at two corpora lutea and you're seeing two ring of fire signs, that is when the whole scenario changes, and that's when we get too worried. If you're looking at an adnexal mass and if you're looking at an endometrioma or a dermoid or a tubercular mass, all those are going to show much less vascularity. So that's another index which is going to help us.
Thank you, sir. So this is an image from ISWAC. This is the gestational sac somewhere in the abdomen. This is the uterus. Can you see this?
Yeah.
So how do you even suspect that this patient could have an abdominal pregnancy? Because everything starts in our heads first, right?
Ma'am, if you see there is an absence of myometrial layer around the gestational sac 1, and that is a thing because that will rule out it cannot be intrauterine pregnancy. So one thing, and the other
See,
thing.
that abdominal pregnancy might be in the liver. My question is very simple. How do you even suspect that this patient could have an abdominal pregnancy?
But it's
Ma'am, there is no liker. There is no
benign.
liker. There is no relation of the myometrium to the fetus. The placenta is close to the chest of the fetus. So that
Your
would make it
uterus
the
and adnexes are
Aberrant
empty.
location, ma'am,
And your
located in the
PTHCG is
pouch.
positive. The first thing is the uterus and adnexa are empty and her beta HCG is positive.
Positive, absolutely, ma'am.
That's
And
when
the
you're going
aberrant
to start
location.
searching, right? Then you're
Yeah.
going to look for the signs. But you have to.
Absolutely.
Sometimes this cannot be diagnosed early, madam. Only if it sometimes abdominal pregnancy is gone even up to second trimester.
Yeah, these are the
So
pregnancies.
yeah,
We've seen
because
Yeah.
The
We have
pouch
seen
of
some-
Douglas, ma'am,
some
usually is
abdominal
obliterated. The
pregnancies.
pouch of Douglas
Yes.
and all, the anatomy is all distorted. So then you
So
know
there
there's
is,
something
there
behind.
is something called primary abdominal and secondary abdominal. Can you tell the difference?
on an ultrasound.
No, as such.
Okay,
Ma'am,
so there is supposed to be nothing to be showing that there is any connection between the uterus, say the placenta sometimes is in the uterus and the fetus is lying outside.
No, primary
the
abdominal is where the
fetus
fertilization, everything implantation
has
happens
happened
outside
outside
the
the
uterus.
uterus.
on the peritoneum.
It's a tubal ectopic or
So-
something which has slipped out and then gone out and
Yeah,
started.
so there is no evidence or a telltale story of any migration through the uterine cavity.
Yeah.
So anyways, I was just seeing a video because there was a question in the WhatsApp group that please give us some link to read on abdominal pregnancy. So actually the articles are very less on abdominal pregnancy, but
somewhere it's very rare.
but I saw a very beautiful
Yeah.
MRI. They do a full MRI and the pregnancy was situated just below the liver and it was almost a 26-weeker. 26 weeks fetus lying below the curve of the liver, below the falciform ligament of the liver, and everything, the uterus and everything was normal. This was a picture on MRI. It's very beautiful on the net. I'll forward the link if anybody wants to see.
Yes. Okay, ma'am. Yes, sure.
Ma'am, please your inputs, ma'am. You're muted, Asha, ma'am.
So, what is the role of free fluid analysis in diagnosing abdominal pregnancy?
It's important to know because it might reveal a hemorrhage inside. If there is more, we need to look for the content or echogenicity. So might be there
I
is
think,
internal.
it gives you a good interface to find the fetus.
True,
If
ma'am.
there is fluid. If there is no fluid, it's very difficult. We as gynecologists are not used to looking at the intestines. Yeah. But if there is a lot of fluid, everything is floating around, you're more likely to find if there is something abnormal.
Yeah.
Right? It may not be blood. If, like Dr. Monica was saying, that 26 weeks ka dikha. So there's no blood there. Na? It's just growing with the placenta somewhere. So there will definitely be fluid. So does where the pregnancy is in the abdomen affect the chances of diagnosis? Means whether it's in the cul-de-sac or right iliac fossa or left iliac fossa or above the pelvis, does it change the
think
chances
pouch
of
of Douglas,
diagnosis?
Yes, above, like when it is
I think
situated
pouch of
normally
Douglas.
above, it is difficult to diagnose. When it is lower down in the pelvis, you're likely to diagnose it at an earlier time. But you should have an high index of, always a high index of suspicion in such cases.
Yeah.
If that index of
Behind
suspicion-
the placenta, behind the myometrium of the placenta.
Ma'am, just a question, Asha ma'am, from my side, since this fetus doesn't have a typical sac and amniotic fluid, but there is placentation, there is a cord. So how does that urination and swallowing cycle of the fetus happen?
So there is fluid in the abdomen. Na? That is where this question comes. Free fluid analysis.
So the fetus has the same swallowing and urination?
That way, otherwise it won't grow.
Yeah, yeah.
Otherwise it will die.
It's another miracle of nature, actually.
All of us are miracles of nature
Ma'am,
only.
amniotic sac तो है
Correct.
ना? Ma'am, the fetus is in the amniotic sac, ना? तो वो वो तो है ही ना, urination and swallowing cycle.
Nee, it is,
No issue.
it is a sac. Sac is there, na, Varuna? Sac is there.
Track will be there. Kuldeep
sac-
sir,
Anji.
ji sir, your
The-
comments.
The thing is, it's very, very difficult. The closer it is to the uterus or nearby, you'll be able to. And again, you can just suspect, you're never sure. Whether it's a tubal abortion, unless and until it's quite big. I've almost seen a 22-weeker close to the umbilicus. That's when I said, the uterus is finishing, and then how come I'm seeing the fetus? And she was in pain, but that was for a different reason. That's when I figured out, the ultrasound done for the first time, that was an abdominal pregnancy. It was taken care of.
Oh,
There was another patient who had gone up to the third trimester, and we were thinking that it's there in the uterus, but it was in another cavity. It was a rudimentary horn, and that kept growing. And we were all suspecting, why is this FGR happening so much? And the first ultrasound was taken out, and then we saw that there were two horns. So that's how we were suspecting that as an abdominal pregnancy, but just went on. That baby was fine. Again, miracles of nature. Whether it was truly bicoordinate uterus or a unicoordinate uterus, because it was a low income set, so they didn't get too many scans done. So that is always and always there. Ji, in abdominal pregnancies, you'll always be in a state of dilemma.
so nowadays also you are getting abdominal pregnancy, sir, to see.
No. This was like
Yeah.
20 years ago, Ji, when I saw. Nowadays,
Yeah, I had also seen some 10 years, 15 years. Sir.
I saw
That's-
during my post-graduation in Varuna is working in was working in the same institute. I saw in Sultania during post-graduation. We did a
Yeah.
So this is a heterotopic pregnancy.
Yes.
It's in the cervix and it is also in the upper uterine segment. So if there is an IVF pregnancy, what are the diagnostic criteria for diagnosing heterotopic pregnancy?
Ma'am, you'll see two gestational sac, you'll see the fetal pole, you'll see the yolk sac, you can see the cardiac activity, very important, and you can see there's no connection between these two. Because the angulation also should tell there should be no connection between them. Sometimes you can see the free fluid also, it can be secondary to the IVF also, but free fluid will be there in most of these things. And when you do the beta HCG's levels in this patient, usually it won't be like doubling time what is occurring. It can be some discrepancy can occur between the rising beta C levels and ultrasound findings. That can have an high suspicion. It can be an heterotopic pregnancy.
So now supposing the image that I showed you, both of them were twins, then you know the sacs would be almost adjacent, right? So then how would you diagnose that this is this and this is this? It's
Yes,
IVF,
okay.
right?
Yes, ma'am.
Twins are very, very common. So you have
Yeah.
monochorionic twins above and dichorionic below. How would you actually differentiate?
What's
So
Your beta
again,
HCG theory and all doesn't work here, right?
What's the question, Asha ma'am? Can you repeat, please?
Just
No.
this, that if there are multiple gestational sacs, what are your diagnostic criteria for a heterotopic pregnancy?
ma'am, you to do the systematic scanning of the uterus, the adnexia, the cul-de-sac, all the surrounding structures. I think in that way we will be able to differentiate whether it is an intrauterine or extrauterine. So very important is you need to have because it's an IVF, you always need to have, okay, it can be high chances of multiple pregnancy. You need to do a systematic evaluation thorough of the uterus adnexia. That's the only way I can tell we'll be able to differentiate. Sir, anything else, sir?
Nothing.
And twins, multiple pregnancies are going to be intrauterine, ma'am. So there cannot be any mistake.
I think we have done with everything.
Ectopic, ma'am.
This is the question. Sir, this is what I would like you to highlight,
Connection
the
is not
importance
coming
of systematic scanning protocols.
When you're looking at intrauterine pregnancy, do not stop there. You need to be looking at the adnexa. You need to be looking at the cervix, the scar area very carefully, irrespective of what the beta HCG levels are. a single gestational sac in the uterus doesn't mean that the buck stops there and now we don't need to worry at all. We definitely need to worry. We need to see, especially in IVF patients I've seen. I think so. Most of my heterotopic pregnancies have been in IVF patients where when I first diagnosed, they said, no, that's not possible. Embryo transfer was done inside. How is that possible? It's gone on. So the clipping of the tubes and all that, I don't know how much is being done still. But you need to be careful watching for any of the reactions. The good thing is in an IVF, they're going to be empty cystic spaces, so they're not going to be ring of fire signs. So that way we are again comfortable that if you're looking at an adnexal mass, you please be very careful in seeing that it should not be a gestational sac. It should not show you plenty of vascularity and especially low impedance flow. That's how you need to be watchful for heterotopics.
Thank you, sir.
The incidence of heterotopics has gone down in IVF because of the recent policies of slightly low transfers. We are not doing now transfers at the fundus. Chitra and Anshu would agree that there is a point of maximum
Yes,
MIP
ma'am.
IV transfer, 1.5 to 2 centimeter below the fundus.
Fundus of the uterus.
Transfer volume we are keeping very minimum. Earlier, we used to transfer 4 embryos, 10 years, 15 years back.
Now a single SCT.
Transfer them with a push. But now we are transferring gently at a lower spot. So the ectopics have gone down automatically and multiples have also gone down. Hopefully they'll, we'll come down to singletons.
No, there are plenty who want a single, so they say transfer one only. And nowadays with the embryo freezing, they're all very comfortable.
Yes,
that,
sir.
okay, we don't lose a cycle, we can always repeat it again.
True, sir. True, sir.
So thank you so much, sir. I request all my panelists to give me one take-home point before we end the session. Each and
Ma'am,
every one.
Yeah, in the cases of abnormal location of pregnancies, you need to do a systemic evaluation. Just don't stop with the uterus. Do the uterus scan, then go for the adnexia scan, then see for the ovaries and see for the pouch of Douglas. So this is a way you have to do the systemic scan for any patient in the first trimester. Or sorry, when they come in the missed periods.
And according to me, if you're doing you should prefer a transvaginal scan, and you should look for the intrauterine if you can see it, and look for the corpus luteum, where the corpus luteum is, so that you don't make any mistakes about intrauterine and extrauterine.
Varuna, your message. Ruby, your message. Please unmute.
I would say it's like think ectopic. Think ectopic.
Yeah, I was going to say that.
Impatient.
Think ectopic.
High index of, yeah, sure, ma'am, first you.
I'm not there to give message. I'm there to listen. Priti. Yeah.
Ma'am, high index of suspicion, detailed evaluation, and detailed clinical history of the patient must be taken before we proceed on with the sonographic evaluation.
And
Right.
correlate with the beta HCG, because in IVF you're doing beta HCG, so you can always correlate, as you are saying, at 1000 you can see a sac, and if you can't see, then you have to think ectopic. So correlate with the beta HCG levels as well.
If there is a history of ART and ovulation induction, then you should always rule out ectopic.
Right.
No.
Ruby, Smita.
Yes, ma'am. First of all, very wonderful or very informative webinar. Thoroughly enjoyed. And like all the panelists said, we have to do all thorough study of the patient, from clinical, then sonography, then blood investigation. All should be go in one setting. We have to think everything. Ectopic should be kept in mind whenever we see for any sonography.
Whenever the pregnancy test is positive and we don't see a gestational sac at the right place in the uterus, we should always rule out ectopic pregnancy. History taking is the most important part. Then we should go for sonography in a very systematic manner, right from cervix, endometrium, myometrium, adnexa, everything. And as Asha ma'am said, the scar should be seen, because sometimes if a cesarean is done in second stage of pregnancy, the scar gets extended like in J shape, and then we have to see the scar through and through to rule out ectopic pregnancy, scar ectopic pregnancy. And then we should also, when the patient is lying down, sometimes we miss the fluid in the pouch of Douglas. So we should examine the whole abdomen also and see if there's fluid in the Morrison's pouch in upper abdomen also.
Okay. And I think my message would be that master your scanning techniques, become very well versed with your machine. Your machine is your best friend, and so are the probes. So as you master your machine, the diagnosis will come automatically popping to you. Thank you so much.
I would like to end with saying that you need to give time.
Yes.
Don't be in a hurry that there are 200 patients waiting, so I can miss this one. Because it is one mistake that will drag you in the medico-legal court and your life will be miserable. And plus, if you lose your patient, you feel bad about it as well. So give time. Don't skimp on that. Read well and give time. Kuldeep sir, we end with your message.
Ma'am, before sir tells, I just want to tell. Sir, thank you, Kuldeep sir, so much. We learned from you today. I mean, a lot of settings, how to adjust TOC. I mean, really, I want to really thank you, Monica ma'am, for giving us opportunity for this. And a big thanks to Asha ma'am. Because of you, I read a lot of abnormal location of pregnancy, so many questions and something.
So
Really, we have updated our knowledge so much. And I thanks.
On a lighter note, as soon as Asha ma'am's questions came, there was such a lot of jitteriness and terror.
I was like, I'm giving one exam, so it just looked like that.
But it was fun, was it not?
Yes.
Yeah. Thank you so much.
Lot of fun.
The clarity you have, Dr. Asha ji, the clarity you have, lovely.
Seriously.
Lovely interaction.
No one can match.
Thank you.
Thank you so much, ma'am and Monica ma'am, giving us.
We are still waiting for sir's
opportunity.
message.
Sir's message.
Yes.
My only and only request and humble submission is always do a transabdominal first and then do a transvaginal scan. I never say just do one scan, because if you do a transvaginal, there's a limit to a penetration that you can see the ovaries and you can easily miss an ectopic, especially when it's going to be at the superolateral area of the ovary, and you'll find, okay, there's nothing over here. So first do a transabdominal, because maneuvering of an abdominal probe is much more simpler, and then do a transvaginal, then make the final diagnosis. That's my only submission.
Thank you, sir.
It was very informative, sir. Thank you, sir.
Thank you so much.
Thank you,
Thank you, ma'am. Thank you.
Thank you so much. And just a little vote of thanks. My sincere thanks to all dignitaries who graced this occasion as chief guest of honor. Dr. Abha ma'am is still there, Kuldeep sir as speaker, and Dr. Asha Jain as moderator. Wonderful panelists and great support team, tech support team. Vishal, you were absolutely wonderful, silent but wonderful. Thank you so much. And till we meet again, our next webinar is going to be on laparoscopic myomectomy. We have slotted down the date of 6th of March. So be ready for another great session with MP chapter of IAGE. Thank you so much and have a great night. Thank you, Aisha.
Kuldeep sir, thank you for staying along.
Please,
At my
thank you so much.
request, you spent so much of your time.
I enjoyed it thoroughly, ma'am. Thank you. Thank you so much. Thank you, Monica. Thank you so much. Thank you, panelists. Thank you. Bye-bye. I'll take your leave.
Bye-bye. Bye-bye.
Bye.